Еще раз добрый день, уважаемые участники конференции. Я попрошу организаторов
Good afternoon, esteemed participants of the conference. I would like the organizers to invite everyone back to resume our session. And before we proceed without further work, I would like to introduce our speakers. That are present in the audience and that have joined the activities of the conference. First and foremost, I would like to introduce Anna Ryabova, Deputy Minister of Communication and Informatization of Belarus. You remember there was the first deputy in the first plenary session. So we always extend words of gratitude to the Ministry of Communications and Information for very tight cooperation in healthcare with the Healthcare Ministry to resolve the global tasks and objectives that the service of healthcare and digital healthcare in particular are experiencing. Viktor Chernyshov is the head of the Republican Scientific and Practical Center of Medical Technology. Unfortunately, Sergey Yenin, the managing director of Information Society, could not make it here because of his health, for health reasons. So let us commence our activities in the composition already on the stage. The first presentation will be mine. It will be a roadmap on shaping the national system of e-healthcare. So once again, esteemed colleagues, Valery, in his presentation today, the minister, identified that the key task in informatization of healthcare in Belarus is overcoming existing fragmentation of IT solutions and the implementation of sustainable and prompt exchange of medical data between various entities in the healthcare system through the implementation of a single platform, harmonized platform. Over the past 10 years, the informatization of healthcare was happening at the budget expense. There was active introduction of medical information system into treatment diagnostics processes, digital paperwork. There's also been a fine-tuning of pediatric and adult registries of the population, medical registries, plus some remote consulting, telemedicine principles have been implemented. Recently, there's been a digital prescription project commenced. Many presentations touched upon it today. And we plan until year-end to resolve the matter of hooking up all the stakeholders interested in this sort of technology, this sort of digital prescription, e-prescription, the pharmacy chains particularly. The basis of informatization of healthcare in Belarus within the framework of informatization and information development 2016-2022 has become the concept of digital healthcare concept development until 2022. E-healthcare is a top priority. Our concept is drafted in line with the WHO European Bureau Health 2020 that was adopted back in 2012. The second document that became the basis of this concept is the Program of Socio-Economic Development for 2016-2020 that was adopted through the Presidential Edict number 466 dated December 2016. Besides that, there's been an implementation of digital healthcare development practices that we borrow from the ICC and European WHO Bureau. The objective of the concept of 2022 development is improving quality of healthcare through direct communication between all the tiers of this clinical services rendition structure. As of 2016, the project of modernization of healthcare system of Belarus is taking place to create the national electronic healthcare system jointly with the World Bank. This concept is about comprehensive information of the treatment and diagnostics process, implementation of integrated medical health records, a system of clinical decision-making, personal office, virtual office of a patient in standard national healthcare institutions. E-health creation will facilitate the switch from automation of standalone organizations to a more commonplace, to a more integrated space for the entities working in Belarus, which will boost its ranking worldwide. Now, to work on the electronic healthcare system, a roadmap has been developed until 2022, roadmap 2022. According to this e-healthcare roadmap, the activities have been designed for these key directions. First of all, this standardization of information resources in healthcare, information provision of centralized information system in healthcare, the development and the implementation of centralized software platform, creation of a system for information protection, data protection, plus information and communication technology framework in healthcare. All these events are not sporadic, they are of system nature, and they are implemented in parallel. The standardization of information resources in healthcare is progressing along the path of developing and adopting industry standards, the directories and the formats for medical information exchange based on international standards. February 14th, 2017, Belarus took a first step in this direction. It became part of the international HL7 standardization organization. Localization of standards of HL7 is happening under the profile of development and information interaction between the centralized system and medical databases, medical systems at various healthcare institutions and other systems which are adopted by the Ministry of Healthcare's order disposition in recent years. Thereby we have united the functioning, the operation of all information systems on a single platform. Already today we have identified, or we have established a system of healthcare institution identification, which is also approved for every healthcare institution out there. Republican Scientific and Practical Center of Information Technology, Medical Technology, is technically equipped to meet the objectives put before it. A resolution has been prepared that all the systems connected to the digital healthcare system must be HL7 compatible by 2022. On top of that, the Ministry of Healthcare has issued a disposition that regulates the validation of information resources in terms of their compliance to HL7 requirements. The next step along the way would be the refinement and enhancement of the profile for central communication, central interaction in this information system, and other information systems in the healthcare, as well as introduction of information interaction protocol with third-party information systems. The information provision of the national centralized system means the creation of norms and directories, directory information establishment. To implement this direction in the RSCPC, Republican Scientific and Practical Center structure, we have created a dedicated department. Legal and directory information, compliant with international standards, will enable the use of not just the national healthcare systems data, but will also contribute the integration at the country level with other systems of e-health, and will become a full-fledged participant of the shared information space of the European region. Within the framework of introduction and development of these activities, the technical specifications, terms of reference, have been established and approved, coordinated by the Joint Task Force on e-healthcare formation. Currently, the process is ongoing for a tender. A tender is ongoing to select a contractor to create a centralized information system. On top of that, activities are going on to select a contractor to create local networks for healthcare institutions. An important part of the centralized systems development is the design and creation of protection systems, systems for data protection that will help minimize and mitigate the risks of information loss or its spread beyond the scopes stipulated in the legislatory framework of Belarus. Currently, there's also activities going on to strengthen the data protection, information security, which means ongoing monitoring of information integrity and protection from unsanctioned and unlawful use. With respect to that, the Ministry of Healthcare has prepared a draft concept for information security in the healthcare domain. All the stakeholders, all the interested parties can contribute with their suggestions and comments to this system. Certain issues, certain matters of information security have already been elaborated on in the previous presentations. Therefore, once again, dear colleagues, we are looking forward to your suggestions and comments in this direction. By late 2021, in compliance with the roadmap, we plan to initiate the connection of healthcare institutions to centralized information system, as well as completion of all the validation activities of the central information system in terms of compliance or in terms of living up to contemporary data protection standards. In line with the roadmap until 2021 again, until 2022, we plan to launch a centralized information system, test operation, trial operation. And in June 2022, there will be already a full-fledged operation phase. These approaches are fully in line with the strategies and the principles of the construction of IT industry in the country. This path is this is a bumpy ride indeed. And for this reason, many speakers today have mentioned that well-weighted, well-balanced approaches are necessary, including the interest on the part of all the entities, of all the stakeholders, the willingness of them to join efforts to create this shared information system, starting with our experts all the way down to the population level, to the ultimate beneficiaries of medical services, ultimate recipients of medical services, and they are the center of the system ultimately. All the way up until the hierarchy of state agencies, public agencies that are going to leverage this information for the population's benefit. Without cooperation, it's impossible to pull off the projects of the kind. At the same time, the roadmap will help us gradually move, incrementally move towards the identified goal. Thank you very much for your attention. Should there be any questions, I'm here to take them. Please, the microphone is yours. Good afternoon. My name is Konstantin Kolomeyets. I'm the resident of Logoysk district. It's close to Minsk. I recently moved there. I was officially registered in the Logoysk district, and I need to go to some polyclinic 26 kilometers away from Logoysk and 50 kilometers away from Minsk. And I realized that there is a resort somewhere very close to my place of residence, but they cannot legally service me. It's like half a criminal, half shady way for me to go there to get primary medical care, because I'm not officially registered with them. So I've heard many presentations already, not a single roadmap. So you're talking about the centralized information system. It's not. It's far from being central. A very important part. The resorts, sanatoria, all of them have medical points with qualified staff that can render high-quality medical services to the nearby population. So the cash flows are also not harmonized. So how do you plan to rebuild the system? Because IT system kind of means that there must be some electronic ID card that will get me serviced in terms of medical services rendition at any healthcare of my choice. Yes, this is a very appropriate and proper question. Essentially, the creation of the centralized digital system. Let me just take a step back to our current situation. The status quo is this. The system of healthcare is built on the territorial servicing principle. For this reason, you're experiencing these issues because you are officially registered with a different medical institution that you, it's different from the one that you live next to. So all you need to do is file an application to the Central Regional Hospital, and you will be reassigned to some outpatient department of your choice, which is next to you. Well, it's more of a private issue. It's more of a specific case. In terms of broader prospects, digital information platform creation. The entities there, the stakeholders there, will be agencies and institutions and companies of various forms of incorporation licensed for medical activity. This specifically goes for the medical institutions which are privately owned, private medical clinics and centers. Besides that, there will be doctors and experts working at those sanitary and resorts that you mentioned, and also primary care points at enterprises and companies. Each patient will receive a single centralized electronic health record, where the information will go to, regardless of where the person got medically serviced. That means a personal office, a virtual office that will receive this aggregated information according to the list about to be specified or about to be prescribed in the law. These medical data will be made available to the patients in their personal office online. You can have a look at the concept of e-healthcare development for more information on this issue. It's more comprehensive than that. The objective of my presentation was not to outline in detail these particular matters that you've brought up. However, it's all been thought of. Accordingly, when we're building this sort of information system, in the long run, you have a very valid point there. It would be very appropriate to de-link or decouple the population from the official assignment to any healthcare institution. However, before we get there, we need to move forward to the creation of the medical system, which will collect the medical data and which will make these data available to any healthcare institution, healthcare provider, wherever in the country. Thank you very much. Any further questions? Thank you. The next person to take the floor would be, it's entitled Central Platform of National E-Healthcare System, delivered by Yuri Chernyshev, head of the Department on E-Healthcare Formation, Republican Scientific and Practical Center of Medical Technology and Informatization, MTI. Good morning, dear colleagues. Oh, good afternoon, rather, sorry. It's a pleasure to see all of you here at our event. I believe that both for you and for us, this is indeed an invaluable experience, a sharing opportunity. For this reason, thank you very much for making it all the way here, especially for the people who have made a long way to get here. So my presentation will be dealing with this central platform of e-healthcare. Digital transformation in healthcare is an objective reality, is an objective process that is happening as a streamlined process with the digitization of other industries. Other industries are going digital as well. It is closely intertwined with proper following of the principles it is built on and proper adherence to international standards. Currently, the level of informatization of healthcare in Belarus is quite high, is rather high. So I'm supposed to switch the slides myself, right? Okay, so the level of informatization in healthcare is fairly high. To automate the operation of doctors, clinics and polyclinics, medical systems have been implemented that are following up on the main principles and the main stages of medical services rendition. However, all this information systems are supporting the local healthcare facilities, and these healthcare facilities do not know of the existence of each other in terms of the data collected by the other healthcare institution next door, which means an untapped potential for the healthcare system. The first plenary session was completed by a very vibrant presentation where the presenter what the speaker mentioned, that various information systems generate a whole lot of interesting medical data, of critical medical data, or data of other sort. This data can only be interpreted by the system that generated it, if it's a proprietary format. There's no such thing as integration at some top tier. So, this is the status quo, this is where we start from today. Combating existing fragmentation in healthcare and the implementation of contemporary, quick manner of information exchange between various healthcare institutions will be made possible through the introduction of harmonized standards in the healthcare system, standards, protocols based on international best practices. One of the standards is HL7 PHIR, FHIR. The digital healthcare system to be built is going to be unique because it will be relevant to every medical professional in every member of population. There's 50,000 doctors and over 100,000 paramedics. Besides that, this system will facilitate provision of current and relevant data about the healthcare system operation at large, and will provide more data, more aggregated data for system-wide perspective analysis and outlook. Currently, Republican Scientific and Practical Center, RSCPC of Medical Technology, is implementing the joint project with the World Bank to modernize, to upgrade the healthcare system of Belarus. And as Vyacheslav here mentioned, a dedicated department has been created, which is directly tasked with the formation of the digital core of e-healthcare. Digital core is essentially this centralized platform, software platform. It will be built on cloud computing. It will be hosted on the Belarusian data center to ensure interaction with healthcare providers. The communication channels, dedicated communication channels of national operators will be used with the relevant standard of protection and security. And again, at the healthcare institution provision level, healthcare providers, various medical systems will become integrated. By 2022, by the time the central platform is launched into full-fledged operation, all the medical information systems that are supposed to interact with the centralized platform, feed data to it, and download data from it. These information systems must be fine-tuned by then with this industry standard HL7 FHIR in mind for full interoperability. Right, moving on. The central software platform, what would be its components? It will accumulate all the medical or clinical data, all the information about the patients. And right there, next to this consolidated storage of the central platform, there's going to be a set of services, an array of services, which are going to ensure interaction with this centralized storage. Accordingly, the lower tier would feature, well, without going to technical detail, certain interfaces have been developed, have been designed, which are going to use these services and APIs to receive and transfer the data back and forth to and from the central platform. So that's a nutshell, that's the gist of the national software platform. The main objectives for its development are the creation of a single harmonized archive of patient data based on integrated electronic health record, the clinical decision-making support system, interdepartmental cooperation, access of patients to medical data, and administrative procedures which are going to be run digitally, right there at the fingertips of the patient in the private virtual office, as well as improvement of services, quality of service of medical industry. The objectives mean the following modules to be made components of the system. The user interface, including the version for the mobile devices. The healthcare portal, which will feature the doctor's office and some documentation for the developments. functional systems of medical assistance rendition, its integrated health record, system for clinical decision-making support, centralized referral system for diagnostic imaging, diagnostic operations, plus QM line management, and possibly even summoning the doctor to come to the patient's home. Plus, there will be some additional quality assurance control measures and the management of medical equipment functioning. Information audit, data protection system, this sort of components will be part of the centralized software system. Also, there will be a module of interface with common information system, module of interaction with various medical systems, and so on. Schematically, the breakdown is shown in this slide here. Further on, I would like to mention some key aspects, some key subsystems of the centralized software system to shed more light on their capacities, on their capability. At the basis of it all will be the integrated electronic health record, which will be created at the time of citizen's birth, and it will be a lifelong solution. This will help all the systems of healthcare provision to work together in a more full-fledged, a more close manner, and to complete the integration. This system, this electronic healthcare record, will receive the information about all the medical interventions and procedures that the patient has undergone based on HL7 FHIR standard data, collected according to the standard. Various software interfaces and user services which will be part of the inner workings of the system. The unique nature of identification of objects and the unique links between them for better integrity of the data in the module will be facilitated by the maintaining a dedicated registry of healthcare institutions, to which end, back in November last year, the disposition of the Ministry of Healthcare was issued about identification of all healthcare sites and facilities. This identification of healthcare facilities will help track the links between the patients, their medical records, and the sources of data these medical records are replenished from. When e-healthcare has been introduced, the patient becomes an active stakeholder in maintaining and preserving their own health. The innovation for the Republic of Belarus will be the creation of a personal office, a virtual way to get access to your medical information, to order the extract and excerpt from medical registries, to create a communication channel with the doctor, get feedback from the doctor, summon the doctor to come to the patient's home, make an appointment, and so on. The format will become different. It's no longer the patient waiting, the doctor waiting for the patient. It will be both ways. The patient will use contemporary technology like tablets and smartphones and PCs to reach out to the doctors. The clinical decision-making support system is also an important bit. This minimizes medical error, or is supposed to minimize the medical error, creates a way for reasonable decision-making. The system of medical decision support, the medical decision-making support, will establish better healthcare services quality for the patient and increase the patient's access. For example, the system can notify various other experts on top of the attending physician that this attending physician has prescribed some overlapping procedure or pharmaceutical. The objective of this centralized system will not replace the expert opinion of professionals, medical professionals, because oftentimes this is a matter of protocol adherence. The system will prevent duplication of data. The next bit is information analytics system. This system's implementation, IAS, will facilitate the accumulation of the data on the patient's health that will be consolidated in the Republican Data Center for the medical institutions to use. The statistical reporting generated by the system with detailed reports over a specific time frame will help create relevant reports about population health at the level of individual patient. This will facilitate rational decision-making, managerial decision-making, geared towards the improvement of quality and affordability of medical care. Another important system is the system of data protection. What I'm saying is, it's clear that the centralized platform will feature some sensitive data aggregation. For this reason, in line with the current legislation, this personal data or this sensitive data will be further classified, and the number of activities will be designed to ensure adequate protection of this sensitive data, both at the central level and the telecommunication infrastructure to get this data back and forth to and from the system, as well as the level of individual healthcare facilities. That's it for my part. Should there be any questions, please fire away. Any questions to Yuri, please? Sergey Yegorov, Yuri, I would like to specify something. We watch TV, and we know that there is an objective to develop smart city, smart urban environment. You watched this Panorama edition. Yes, so urban environment is about to be restored. We note that the elevator cannot go to this zeroth floor. What I'm saying is we cannot really run before this progress. The WHO speaker has provided some valuable comments. If I may, I will cite some of the points. Digitization challenges our understanding of how and when medical help can be rendered. What do we see today? The elevators are 2 centimeters shorter. We're talking about barrier-free environment. Today, at the time of overhaul, we can apply some cloud solutions for security for every home construction, every house construction. We can collect data. So I'm metaphorizing here. What we need is we will need to reform our housing stock. So you, as a manager of your team, you are aware of these construction norms and principles medically relevant. Unless you're promoting these initiatives, unless you're talking about them, unless you're making other experts aware of them, this will be a very late development for us. And one final bit. Russia has declared 80 years of active longevity, quality of life, at least until the age of 80. So you're supposed to think about the interaction between our housing stock, between optimizing the barrier-free environment, and how does e-healthcare fit into this new emerging housing stock. We need to think about it. We need to implement this as quickly as possible. So how do you see this implemented? Thank you. Well, this question is quite broad one. Well, you can receive assistance from the Presidium. I'll be happy to contribute. Okay. So please, the floor is yours. Yes, indeed, the colleague has raised a question in a very valid manner. That full digitization of our economy would mean overhauling the standards that we live by, the standards of our life. We are taking very evident steps in this direction. Our smart home standard has already been designed. Of course, it's not about the finer things that you're talking about. It's more about sensors. It's more about smart home, the status of your apartment, what's happening in there, and the ways to control it. You might be unaware of that, but to this end, we've created a task force, technical committee for the digital transformation. 40 stakeholders are part of it. The stakeholders from every industry who are supposed to contribute as to how the digitization is moving on and how can we make it better, how can we progress in a better way, in a more standardized way, more harmonized way. So please, can you forward your suggestions to that committee? Yes, thank you very much. We're all aware that there are many commissions out there, task forces out there, but the elevators are being replaced right now. And the elevator is 2 centimeters more narrow, so you cannot take a baby carriage in it. Mogilев Liftmarsh is not producing the right kind of elevators. And all the commissions that have been making sessions and meetings year after year, they're not responding to this changes, to this violations. And if we're talking about standardization, the construction people are physically unaware as to where the digital transformation is happening. Clayton's presentation and the three messages that he voiced. I believe this should be the desktop kind of a Bible for every person to make use of. One final bit, Scout's honor. The Putin was addressing the national community. So do not look at those volumes that have been written up before. Let us think about legislation improvement, the way it's supposed to be, not looking back, not necessarily looking back. To that end, to have a must-have, to have a valid, decent legislation, you need to envisage, you need to have a vision how this future might come together. And then this would be the benchmark to be providing the legislative support for. I don't think that any suggestion from the audience will get this ball rolling, unless this matter is discussed by the most advanced digital leaders who are promoting digitization. It's a big question, what are we aiming at? Okay, please let me respond. Your points, some of them are quite valid. I do not think that Russia, again, regardless of the fact that you've been referring to Mr. Putin's statement, not everything is nice and bright. In some aspects, Belarus is doing even better in terms of standardization of construction, of our housing stock, and so on. Yes, there are many commissions, you're right about that. But I'm not talking about the commissions. Technical committee or task force is the one designing the standards. It's not a working group that just sits there and discusses. The technical solutions are only possible because of this. And next, you mentioned we need to switch to overarching models, common models. This is what we do already. This is what we are doing. These infrastructural models are already being developed, so your claim was not that just. Okay, you mentioned final bit. Okay. I've discussed with Clayton, all of this requires physical transformation, physical infrastructure transformation. It's not digital, it's not network solutions, it's physical infrastructure, the environment around us. For 5 years, we've seen the billboards, the waste, those raccoons on the billboards are doing something. Ultimately, for several years, we see sustainable development topics on the billboards recently. But still, nothing is moving forward. 85% of the waste are going to the landfills. Housing stock, dealing with that without resolving elementary sessions, no matter how many commissions you throw at it, no matter how much paperwork they adopt, these kind of matters are kind of universal, versatile. And in this case, we're not talking about what Russia has and we don't. We're talking about the approach. We should disregard the existing legislation. We should take all the innovations in repositories and industries, the university platform. This must be represented as an information model. For how many years the system of education has been talking to us about lifelong education? An engineer, technologist, lawyer, economist, doctor, 6 years of education is not enough for them to get everything, to get anything together, to put anything together. That's a sad thing. So unless we prioritize these issues in the housing stock, in practice-oriented education, and new active stakeholders of that, unless we do that, well, nobody will know how we can interact. Well, thank you very much, dear colleague. Nonetheless, I would like to say I'm not the right person to talk about the waste being taken out to landfills, but for the smart home, it's done. So this is what I can attest to. Okay, summarizing this discussion, the comprehensive approach to digital economy development is kind of a red line throughout this. The efforts must be joined to switch from practice to, from discussion, from theory to practice. So we heard you. This opinion will be recorded and it will be communicated to all these stakeholders. By the way, the Vice Prime Minister will be here tomorrow, the one in charge of digital economy of the country. We will include these items into the discussion. A small contribution, if I may. So we're talking about digitization of healthcare. I started my presentation with this. This process is ongoing, digital transformation of economy at large. The Belarusian economy is going digital. At this point, this is what we have. This is all delegated to the level of ministries who are dealing with it. And you're raising a very valid point. It is indeed voiced in our country at all levels. There must be some entity that is going to govern the digitization in all industries. It's not supposed to be happening in a fragmented way. The individual ministries, line ministries, must not decide on their own, even by creating a dedicated department, how they should go digital. These processes are already surfacing. Digitization of all industries out there. Any further questions? Yes, thank you very much. Thank you, Yuri, for your presentation. Esteemed colleagues, now we're about to switch to more presentations of a more private nature, more narrow scope, that are going to talk about successful cases of implemented projects. I would also like to comment on the fact that since we dealt in quite much detail of e-healthcare platform, let me communicate it to everybody how much has been done over the course of the past year since conference number 1. Indeed, this department that was formed has done a lot of work, has progressed in terms of analyzing similar systems, in terms of what has been done in the country. And it developed certain approaches which have been outlined in a number of presentations today. So sharing this experience today, we would like to hear other application points, other ways to improve digital systems. Today's conference is entitled e-healthcare, digital healthcare. So let's talk about healthcare. And let's talk about the approaches that are already out there. So the discussion is not yet closed. It can be continued at various forums, at various platforms. So tomorrow there's another working day. And, we value your opinion. Let us continue our activities. The next presentation to be delivered will be about the comprehensive approach when building e-healthcare in St. Petersburg. Evgeny Kogan, key architect of the state information system of St. Petersburg. Good afternoon, dear colleagues. I will not talk about the entire digital healthcare of St. Petersburg, although I'm very inspired too, because there's quite a lot of progress that we've achieved along this path. This presentation will be dealing with the basic approach, the more fundamental approach. What is this basic approach, leveraging worldwide experience? Sir Isaac Newton said that if he could see farther than the others, it's because he was standing on the shoulders of the giant, referring to the previous experience, previous expertise. So leveraging the standards of medical data exchange, it helps us use these shoulders of the giants to use cutting-edge technology in medical computer science. So this is the primary idea. Let me talk about how St. Petersburg got to it and what was the result. What the result was. Right, so healthcare of St. Petersburg means 5 million patients, 30,000 doctors, 250 medical organizations, municipal organizations, 30 federal institutes, and several thousand of private medical centers. We don't even know how many of them are there. 2,500 are medically licensed, but you see them, several of them, in every street you walk. It is these days that St. Petersburg is related to integrated or comprehensive approach. Half Russia is coming to St. Petersburg to share experience, to imbibe our experience along this path. But this has not always been the case. St. Petersburg did not approach it at once. Until 2011, more or less, every medical organization who could and wanted, they selected and installed medical information system. And that's pretty much it for what was happening in the informatization of digital, of healthcare going digital. Plus, there was the medical insurance, but there was a more dedicated, more private system. In 2011, according to the overhaul program, modernization program, the regional level appeared, regional tier emerged, creating this integrated regional tier, the city went on to tackle various objectives in various ways. For example, there was an attempt to make a centralized staffing system, well, to make sure that all the staff of all healthcare institutions will be centralized in some information system. Together with that, there was an appointment system. Also, it was harmonized, it was universal, although it became integrational after several months of trial and error. So this system is integrative. They did not demolish all the registration departments in all the polyclinics and create one central. No, they integrated them all in a single chain. On top of that, there was an attempt to create a dedicated, versatile system for the inpatient clinics. In the 3 clinics, these existing information systems have been decommissioned, and they installed the system that St. Petersburg as a city picked as the key one. Several years on, well, 3 years, 2014, this system didn't fly. How comes? It was a great software system. It was working fine. So how comes, having been installed in 3 inpatient departments, in 3 inpatient clinics that were ready for it, it did not perform to the best of their expectations? I believe the main factor came to stage here. The main factor that is impeding the introduction of medical healthcare system. There are 3 of them, by the way. Do you know 3 factors which impact the implementation of medical healthcare system? Who knows all 3? Okay, just a few of you. So these 3 factors, factor of the first person, and first person, all the 3. So whenever we are implementing some software system, having paid municipal money for it, then the head doctor is not responsible for it in any way. It was not his choice, it was the municipal, the city's choice. So that means when actual implementation happens, when actual things need to be done by that head doctor, well, he or she will be kind of a passive bystander. So the systems that the head doctors have selected themselves will be the ones that fly. So as of 2014, the city of St. Petersburg is moving along the integration path. The healthcare institutions are the ones selecting the systems and installing them. The city is creating the regional level, the city level, and creates some rules of play, how these information systems must interact with each other. Let me give you 3 examples of such integration projects. The first one was the doctor's appointment. If you want to make a doctor's appointment, well, there are 350 municipal polyclinics and 20 non-state-owned or private-owned platforms. 370 polyclinics altogether. There are 13 various international information systems. So this system is quite in demand. There are many referral or many appointment tickets are produced. Half these tickets are borrowed online, taken through the online procedure. And it works like this. No matter how you receive that ticket, mobile application, visiting a website, or you go to the central portal and you get that appointment ticket, you select which doctor you want to go to. The system files your query to the polyclinic information system that you want to be recorded to, and you're picking the ticket to the desired time. So this is how medical information systems work. This is the harmonized way of their operation. The second project that the city implemented was the exchange of data for laboratory studies, laboratory tests, research. So why this project? If you want to create an information system for a doctor, then you need to have the doctor facing it. The doctor needs to benefit from it somehow. So what does the doctor do? They want the test results to be processed. So back in 2014 when we started, this was the adverse picture back in the day, where various medical systems were interacting, or 5 of them. I've recorded 5 of them here, 5 lines. The developers came to us and they said, like, it's our 10th integration with the medical system. Can you come up with a harmonized system for us to have an easier time integrating our new development? So this was the time for the standard selection, the standard of exchange of laboratory data, and the standard of encoding of lab tests, because the encoding systems varied from laboratory to laboratory.
Как раз в это время стала возникать
Now, around this time,
очередная версия стандарта
the
HL7.
new version of HL7 Fire emerged, or started emerging. We find it very lucrative in many ways. First of all, it was the first HL7 which was open and accessible. You were not supposed to pay anything to get the standardization paperwork. Secondly, HL7 Fire people ran various hackathons, various meetups where they educated everyone interested in this technology how to navigate, how to use the standard. So over one day of programming, of software coding, people could master it and create their first application based on HL7 Fire standard. A development team emerged that translated this whole thing into Russian, the specifications and documents in Russian. So everything was kind of lucrative for us to move in. So we went for this standard. Ultimately, what resulted is all city information technology. All of St. Petersburg works in this platform. The medical institution forms a request for laboratory test. This laboratory test is fed into the centralized system. Then when the sample for testing is coming to this laboratory, the laboratory queries again, is there any information about this patient that was provided? And then, once the testing has been complete, it files, or it gives the test result, it puts uploads this result into the city system. This city system can be cross-queried by any medical institution that is authorized to use this information. So this is a quite renowned project. The Minister of Healthcare came to St. Petersburg. She visited the Information Analytics Center. It was the one and the only time when the minister came to visit us. So we have launched this at the city level. The patients are indeed using that. All the test results that you've submitted to your local polyclinic can be made available at the local, at the centralized database. So almost everything, yes, I see some skeptical looks that you guys throw at me from the audience. Almost everything. Okay, so there is another important result. It is about the fact that since all the testing codes, the ways to encode the tests are harmonized, all the results are put into the centralized database. Can you guys hear me? Well, the interpreter can. Okay, sorry about that. So we can show the dynamics of laboratory results, regardless of which labs they came from. This was the first ever experience. Even in hard copies, a doctor cannot really backtrace the dynamics, or forward trace the dynamics, because the results from various laboratories come in various units, in various different formats. There's no way of easy tracking them. Okay, so this is what we started showing to the doctors. Now, the third serious endeavor, the third serious project that we've embarked on, it's still live. It's an integrated healthcare record. This is the architectural three-tier structure. The lower tier, local healthcare institutions, then there is a leader, and there is a federal level where these results are fed according to the federal legislation. Now, the doctors are working with their medical information systems in this first tier that you see. And the managers and patients, managers of healthcare institutions and the patients, they work with the citywide resources. The commencement of EHR for St. Petersburg dwellers happened last year. We're approximately midway. Every citizen of St. Petersburg, well, there are 5-something million in total in St. Petersburg. Unfortunately, not all of them are there, or there might be some duplicate entries because the system of identification is something separate. It can be talked about separately. But we collect, as of today, we collect information about 50% of medical interventions and medical health services.
Теперь два слова о том, чем нам на самом деле помогают
So,
медицинские
in a
стандарты.
nutshell,
Что означает
how medical standards help us, and what did I mean by standing on the shoulders of giants? When you're making an information system, there is 1,000 challenges that you need to tackle. Like, we want to merge the medical data from various institutions. So we want to provide continuity of treatment. HL7 Fire, CDA, CCDA standard, people have thought about it. This does not mean that we need to replicate it one-to-one precision. What we need to consider is we need to borrow this practice and avoid wasting hundreds of man-hours to develop it and develop it from scratch. Clinical decision support system. Not always we have the data to feed into this system. HL7 Fire is good because it has CDS hook, clinical decision making support hook, which has generated some rules, and it requires, it enables feedback. Another challenging task was to maintain the treatment plans. Treatment plans or care plans is something that the doctors need to fill out. The goals of treatment are not properly adhered. So how can you model something that's not clearly described on paper? We go to the HL7, there's a special structure for it, care plan resource and goal resource. So HL7 Fire does that for us already, plus automated control for clinical quality. CQL is a special language that exists to this purpose, automated medical services quality control. So, dear colleagues, what we have right here is an actual patient history, electronic healthcare record of St. Petersburg dweller. This is a so-called integrated history. This screen collects all the data relevant to the patient, collected from, taken from various information systems, and this is the comprehensive format, compact format, that the patient can the doctor can quickly look and know more about the patient. First of all the conditions, all the diseases are summarized. Left-hand column, you see some diseases there. How comes with why do we believe it important? How the doctors use it? So, for example, this anonymized patient is a 13-year-old boy. So I've talked about several diseases, respiratory diseases, section 10. If he comes to an appointment and is coughing, the doctor will obviously prescribe something to fight that cough. However, if the doctor goes to the blood diseases, he will see some serious qualitative defects of platelets or ITU, idiopathic platelet purpura. So these conditions will help the doctor avoid potential complications from malprescription. So this is why it matters to centralize all the data. Another important bit, whenever we're putting together an e-healthcare system, we often fail to realize what we want as an ultimate result. The big aim out there is clear, everybody's doing it, digital healthcare. Is it only about convenience for doctors and patients? Many stop there. Yes, that's all we want. However, this is not the case. Essentially, maybe inadvertently, subconsciously, we want to receive ultimate benefits for the patient's healthcare, for the patient's health. So let's talk about where we expect the population's health to become better. So these are the 5 lines, 5 stages, 5 major projects in e-healthcare of St. Petersburg, 3 of which I've elaborated on, because 2 have been completed and 1 is ongoing. So, for example, first one, making an appointment with the doctor. It's important that if this electronic health record is available, the patient will go to the doctor at the right time. If they fail to, they will miss out on an important visit and they might deteriorate their health. Lab results, it's not just about prompt testing, it's also about prompt response by the doctor on adverse clinical findings, adverse lab findings, so that doctor can summon the patient much faster, unlike with the hard copies. Electronic health record, to not miss the important part, like blood conditions with respect to some coughing problems, some nosological registries in this electronic health record. Again, proper decision-making and quality control for doctors and decision-makers, the leaders. The proper decision-making, the appropriate decision taken by the doctor will contribute to the patient's health. And the doctor will see this kind of a beacon of hope later on. Thereby, the managers will have the opportunity to control the quality. And ultimately, what we expect from digital healthcare is connecting the apps for the patients. It is known that human health is by how many percent, 30, 40%, it rests on the healthcare system. The other 60, 70%, it rests or it depends on how the person lives their lives. So for this reason, it's exactly connecting the patients to caring for their health will get us to a new level of healthcare and quality of life for patients. So this integration of applications for the patients will contribute to better follow-up, better help for the people. Now, for all of those aware, I would like to remind you of the Gartner model that was offered in the year 2014. So you might have seen it before, some of you. If you remember, Gartner company referred to 5 tiers. Tier 1 is generation 1 is the collector system. They have been around for a long time. They basically help people working with the data, facilitate, enhance their work. Second generation is the documenter. For example, exchange of laboratory data or electronic healthcare record is right there, the documenter. Collect them in a timely manner, show them where appropriate. Generation 3 is the helper. The helper is with some additional blows and whistles that can do the math, for example. If the doctor fell short somewhere, this system will intervene. Generation 4 is like when the system is your peer, your colleague. So these generations have existed at the time when Gartner put this review together in 2014. This information systems in Norway. Level 5 was the mentor. The mentor was claimed to not be available, and we do not know how soon they will emerge. But the mentor generation programs, they will emerge at some point. Not today. You cannot really draw a line between the colleague and the mentor. So what has emerged? Integration systems have emerged that can create a consilium of doctors, a team of doctors working on the same patient and get the patient involved into the treatment paradigm. So this is tier 5, generation 5 of the utility that e-healthcare information systems can make happen for the patients and the doctors. Now, summarizing the benefits of integrated approach, I would like to say that first of all, it joins people together, it combines efforts, it brings people together, professionals of multiple domains, it promotes competition. We failed to discuss that, but it's obvious. And by leveraging open standards, it helps stand on the shoulders of the giants and comply with the global standard, global level. Thank you very much for your attention.
Пожалуйста, вопросы.
Okay, questions.
Пожалуйста, пожалуйста.
So please. Валерий Шумилов. Well, first of all, you're an engaged person. Thank you very much for the presentation. This experience is invaluable. And this experience is very important since we are at the outset of our journey. So let me refer to a specific point: automated medical care quality control, automated control of quality assurance. So the doctors make no errors if they're idle. There are medical errors, this way or the other. So I would like to know how you're dealing with that in St. Petersburg, medical error handling. How different you are from Finnish approach. The last meeting featured a presentation by Finnish expert on medical errors. And how does St. Petersburg go about medical errors? Clinical anatomical conferences. Have you taken all that into account? Do you take all that into account in your system, in your e-healthcare system that you run?
Да, спасибо за очень интересный
Yes,
вопрос.
thank you for a very interesting question
Ну,
indeed.
я в данный момент не
Well,
представитель органа
currently
управления
I am
здравоохранения,
not a manager
а всё-таки
in healthcare.
представитель,
What I am is, what I do is, I'm the main expert on informatization of healthcare system. So I will not talk about, I will not talk on behalf of my entire directorate. We informatizers, or
отношение к тому, как сейчас в России учитываются врачебные ошибки.
people about going digital, we are very negative about the way medical errors are recorded in
Скажем,
Russia.
мировой уровень ошибок.
I can give you several examples when
Сейчас
the
я могу ошибиться
global
в
level
цифрах, но
of
не в количестве.
errors, medical errors. So I might get the figure wrong, but not the
Мировой уровень там, 2%.
overall situation. Post-op complications, global 2%. Statistically, Russian is 0.2%, 10 times lower than the global level. So there kind of no post-op complications. So this is the way the recording system works. So we are very negative about how it runs. What we believe is, currently, the medical errors are not properly recorded in Russia. Unlike Finland, we are very tight with those guys. We know how it's very carefully handled, and the doctor does not find it shameful to say that yes, he or she might have made a mistake somewhere. Only idle people make no mistakes. That's true. Russia is only moving towards this. We hope that automated quality assurance of medical care will help get there. It's a very appropriate question. Thank you for it. And at the same time, it's not just about recording the medical errors. It's also about the culture of attitude. It's not a criminal negligence. You cannot really imprison the guy or the girl for making a medical mistake, a medical error. So what we need to think is a constructive way to avoid this sort of errors in the future. Thank you, Evgeny. Thank you for the comments. Please. I have a question about the money. I realize that your healthcare is going digital incrementally. So have some of the decisions proven useful? Have you improved your cash flow, bottom line? Budget funding, involvement of private donors, private capital. Your final statement was improvement of competitive environment or something like that. So competitive environment and cash flows in the healthcare. Has anything changed for the better? Well, I would say that it did not deteriorate, because initially this was the understanding. The industry was there, and the industry was buying solutions for St. Petersburg from other places. If St. Petersburg had adopted the mono system, well, there would have been no competition. So in this case, yes, we have made things a bit better. At the regional level, yes, there is one solution, our solution. Well, that's right. When there is a single solution, if it's just one solution, it's a monopoly, the tariffs are appropriate. So this was one of the valid points that we've taken to the municipal leadership. We asked them to not destroy everything, all the information systems that were already installed. The back then economist of the city, she's a financial person, she's very good with numbers, and she was asking like 5 or 6 main systems are working in the city. So if any change happens, I need to fund the change in six times over and over again. So let's demolish the whole thing and create a single solution. But we were able to prove that the tariff in that case, in the case of a single system by a monopolist, will cause the tariffs to go up much higher than 6 times. Another question. So you've been talking about this integrated approach that you're preaching. It underwent certain evolution stages, and ultimately there was the model that you see up and running. So the question is, with the information at hand, that that was accumulated in medical healthcare system, medical information systems, what was the decision what to do with this information? Whether you need to transform it to the EHR in the format that information is available now, the data is available now, or just maybe some excerpt, some dedicated excerpts that would go to the region level. So what was the solution in your case? Yes, it's a toughie indeed. Thank you very much for this question. It is a toughie. It is related to the evolution of medical healthcare medical systems. because
разного
the
времени.
data comes in many flavors up there, various level of detail, various time frames.
Сейчас мы находимся в середине процесса
So
сбора.
right now we're midway in the data collection process. I've shown you that we're not collecting 100%, we're collecting roughly 50%. And the quality of the data that we accumulate now, that we collect now, is below standards from our viewpoint. So what we're going to do is we're going to fine-tune the quality of data that we're collecting now, and then we will help the local medical information systems to contribute whatever they see developing in the future. Another question, if I may. So, Evgeny, you said that there are some rules of first-person decision-making, first person, in implementing systems. So this was the reason why you discarded the one-for-all approach. But head doctors are different, medical systems that they run are different. But if the head doctor is replaced by a different person, so this disruption of continuity, lack of accountability, and blown-up costs, are we going to face that? Yes, thank you very much for this appropriate question. Indeed, this issue is out there, and when head doctors come and go at medical institutions, we see that the information system does change, but not at all times, not across the board. The most painful point is the time of its implementation, when nothing was there and it's implemented from scratch. So how comes it's a pain point? Well, it's because you need to revamp all the processes that you've been running in the medical organization. It's not just about the implementation of the system. The contractor can do it for you. The vendor can do it for you. So if the head doctor signed that paper, then yes, it will be kind of a ball rolling thing. So yes, it's important to get the ball rolling. Then it's a downhill climb. Okay, any further questions? Thank you. Thank you, Evgeny. The next presentation is to be delivered. It's entitled Technologies and Experience of Intersystems. Dr. Tsili, the floor is yours. He's the development for innovative products, the director for innovative products development, Intersystems.
Thanks very much. First, I want to thanks for having me here, and also thanks to the interpreters. You guys have done a fantastic job. I was able to understand everything has been said. And today I want to talk about project experiences that we have, Intersystem has done all over the world. And in a nutshell, we have been building healthcare technologies and for over 100 countries for 40 years. And so it has been a tremendous, I think, opportunity for us to come here, talk about our technology, talk about our experiences. I think that hopefully you will find it can be helpful to your overall planning as well. The key thing I want to say is, as the gentleman earlier was talking about, he was seen by other doctors, and this is a typical phenomena in the U.S. also. A typical elderly physician is seen by, elderly patient is seen by 7 physicians in 4 different locations, so it's very common. But more importantly is also the information about the patient resides in many places. And so when we are talking about a regional or national healthcare information technology, if we have the focus on a single patient, we have to recognize that information already exists in many places, pharmacies, doctors' offices, hospitals, and in many places. So the first thing that we need to do is to make sure these information can be shared and can be aggregated if needed. Another very important aspect of it is the increasing amount of healthcare data that's being generated. So this is a graph that shows, in general, the amount of data that's generated by a variety of technology, but healthcare is very unique in that sense that the speed that's generating data is much more than anything else. I'll give you an example. Even not only my watch generates data, even my ring now generates data as well, and it gives me a lot of very useful information. So the amount of the data that gets generated, so we want to make sure the technology can support this growth of data. That's very, very important. But more importantly is also around the human's ability to interpret data. Several years ago, I started a genomic project that aggregates a lot more data than before. And when we look at the genomic data, it's even more crazy, the amount of data that is now available for a clinician, for a physician to take care of the patient. So, but the human cognitive capacity as a doctor, this is embarrassing to say, and we can only take 5 facts. And anything more than that, we need some decision support, we need some logic, we need some rules, and that becomes very important. Just recognizing the human end, you don't take all the information that are being pushed to you. So it's very important for us to summarize it. So the InterSystem, our overall technology platform foundation is, there is a foundation, this is what we call the Iris Health, and this is where we focus on managing the data. Lots of data coming from many places. Let's make sure it can be managed centrally, distributed, for example, and shared. And the HealthShare is our product that ensures that sharing of the data occurs, and also provide a clinician with a view of the combined data set. And more importantly is that we are not the only company that builds software. So on the right-hand side is where the partners can use our platform, use the data, and to build their own technology, build their own applications on top of it. So I'll talk about 4 projects around the world. And these projects represent our journey. We started doing this the regional health information technology way before a lot of people. And so our first project I'll talk about is around the diabetes, and which is actually built on in the region. And I will also talk about FHIR, which is a project we did in London, in the UK, and also talk about another IHE standard that we implemented in Italy, a fairly large population as well. And earlier there's a discussion about artificial intelligence, so I'll talk about how we are supporting the artificial intelligence as well in this regard. So the first project is about Rhode Island. It's a state right next to Boston. This was our first regional health information exchange project. That was back in 2011, a long time ago, and consider that how far we have come along. What's interesting there is there are many hospitals, about 12 different hospitals, 4,000 providers, 400 medical practices, and also insurance companies, employers, and this is a perfect picture of information is everywhere. And on the other hand, in this case, as a patient, you want to have access to all these data. And so the focus that we have is around safety. Safety was the key thing from a state regulatory point of view. Earlier, there's a comment about the national policies and so on and so forth. So in that particular state, the key priority is around the safety. So during the break, the reporter was asking me, as a patient, what do you want to see? So this is a patient point of view. If I'm taking multiple medications that was prescribed by different providers, I want the system to know about. I want everybody to take care of me to have access to it. If I have documented allergy in a recent clinical encounter, I want the other physicians to know about it too. And if I have done a lab test another place, I don't like needle sticks. My daughter hates needle sticks. You know, if there's no need for it, it'll be ideal if I don't have to do it, and so I can access the previous record. And earlier there's a comment talk about the decision support. You know, drug-drug interaction, drug allergy interaction, drug lab decision support. Those are very common. So in order to do any of these decision support, you need a solid foundation to have all these together. So this is a view of our clinical record, very similar to the earlier example. We capture all the clinicians' diagnoses for the patient, the medications, all the visits, the lab results, the observations, and the procedure test reports, radiology images. So all these are available in this particular web portal. And it's also available on the mobile devices as well. Keeping in mind, in 2011, it wasn't that popular, so we didn't quite have the mobile version. But recently, we made the mobile version on the smartphone. You can do that as well. What's interesting is that the policy, because it's state funded, it's funded by the government, they started looking at several usages. It was very interesting. The first was around duplicate tests. This is around how to reduce waste, things that we don't need to do. So they build an algorithm and they identify certain tests or duplicate in a way that you don't need to order it. And also there is the public health was looking at sexually transmitted diseases. It's a public health issue. They want to see where the patients are getting the test, and also are they getting a follow-up test as well. It became very useful for the public health departments. There was a comment about analytics. So this is also a very early on project that we decided to do. And emphasis is around the quality improvement around diabetes. And I know that in Belarus, about 10% of the national healthcare expenditures on diabetes. It's a global problem everywhere. So in this case, they're using the data that are being aggregated and to build a quality improvement program. I'll give you details about it. In addition, they're looking at hospital utilization, and also with the intention is to reduce waste and try to reduce the hospital utilization. And this become a very useful tool as they build a quality improvement program. So the quality improvement is interesting. This is for the medical directors, for hospitals and the physicians. Now they have a website they can log on, they can look at their performance. The performance are focusing on the metrics using the lab results, using the observations, and a variety of data that's already aggregated on the information platform. And there are 26 medical practices participated, so each one of them, they're represented by a bar. If you're red, that means you're not doing so well. And you can compare them across the board. So for a region, for government, this becomes very useful for clinical quality. And so that's the key point. Now you have a common view across all the practices. And you can look into individual practice. I'm the medical director for a practice. I can look at my own performance. I can also go into the provider or physician level, look at each one of them, how each one of them is doing. What's very important here is that the quality improvement becomes data-driven. It's not something you have to fill out a form, right? It's not self-reported, which is usually not accurate. And what's fascinating was the result that they achieved only after a year. They found that, first of all these performance quality metrics, they were able to improve, and all the practices was able to meet the goal. And also on each individual measures, they're able to make an improvement as well. So having the data from a quality point of view for the performance made available become very useful for them to improve it. In addition, they set up notifications. The example is very simple. When a patient gets sick, usually it would be useful for the GP to know about. If I go to the hospital, if the GP knows about it, the GP can do a better management. So having this notification, even though it's not about data aggregation, but turned out to be extremely valuable. We found this a recurring pattern. It will be useful for your government to consider as well. This is a project in the United Kingdom. It is FHIR. FHIR, we're very excited about FHIR. So finally, there's an HL7 format that's very modern. It represents an information model that's standardized. And earlier there was talking about hackathons. We see thousands of companies that are building applications on top of it. And it's just fantastic. So we have been an early adopter of FHIR, doing many projects. The UK project is our first project outside the United States. So we're very excited about it. And the concept is very simple. And really from the baby when they were born, the project is called the Red Book. And, but when the baby was born, there was animation. It was more even funny. In the interest of time, I just say, okay, show you the picture. But the baby does go through many institutions and organizations. And in the NHS also, they did a very good job of trying to aggregate all the data, sharing all the information. But what's fascinating here is that they used to be, every baby has this Red Book. And I found this is it's a global thing. Many countries have a book like that. And, but replace the Red Book with this. So now every baby, now you can have an online presence, online record. You can go there and look at everything, and it become phenomenal. And everything is powered by FHIR. That's the most amazing thing. So we're very happy about that particular project, and really show that using FHIR, using a modern standard for a national government, really for a baby, everybody cares about, it was just very doable. So we're very excited about that project. Of course, we supply many of the underlying technology, keeping in mind that this is also additional software companies that build additional solutions on top of it. But this is a fantastic example. Next, I want to talk about IHE. The IHE is a fantastic standard. Many of you have known that this has been a global organization pushing many of the standards around sharing data, sharing document. And our team loved this place, and it's in Venice. It's a Veneto. and I've only been there once, and I was hoping to go there again. But what's fascinating is also the type of technology that they have done, and I was impressed, while they are enjoying life, but they also done fantastic work. And so a couple of interesting metrics. So first of all, from a EMR adoption point of view, they are higher than many of the Italian, I would say, states, the European averages. It's very, very good. At the same time, they also have a fantastic, really, from a national health system point of, from a regional health system point of view, they have close to 5 million residents, 23 hospitals. So it's a fairly complex, fairly large, and everything, and not just the Venice, but there's also a large region that they take care of. They issued a bid, essentially is focusing on using IHE as the standard to help them to build a XDS repository. It's a little bit technical, but simply meaning that there is a document they want to store centrally. And the document is generated by all the health systems. And they're looking at multiple use cases. So when they ask the vendor, they say, could you actually prove to me you can complete all the tasks? The two categories of tests are focusing on the XDS registration. I have a document, I want to store it, so you register it, so on and so forth. It's very, very useful. And also to be able to read it. So I have XDS repository. If a third-party system want to read it, how can you effectively support their reading as well? What's fascinating about all these standards, I have to say, just like a FHIR, IHE, from the beginning, and they talk about the security and the privacy and the consent and audit trails. So many of these, particularly for the national systems, they have heavy emphasis around the security, around the audit. And we see also FHIR standards has tremendous of those as well. And so I think this is very, very good. So our project, we did a very good project. Every month we have about 42 million documents being processed and stored. So far, this was presented a few months ago. By that time, it was about 600 million documents in the XDS repository. So this was also a very good project, just to highlight how we are supporting IHE standards in this case. The next project I want to talk about artificial intelligence. This is an area that is fairly large. It's our sort of a second customer in the United States. It is in New York. They have about 16 million patients in that particular region, very crowded, and in New York, everybody just like squeezed together, and lots of people, many hospitals, and about 600 different type of systems, and in many thousands of locations, and they are contributing data, sharing data. So we have been working with them on building out the regional information technology for a long time. But they generated was very interesting. First of all the 16 million patient data are all shared and aggregated. And in addition, earlier I talked about creating the notification so that when a patient went to the emergency department, now all the patient's GPs and other specialists will be made aware. So the notification become a very important one. So they generate about every month about 1 to 2 million notifications. So it's a very, very large transaction. About 4 something million, I think, I'm not sure it's reflected here, but about 727 the care summaries that are being shared with other providers. So the volume is very high, for this particular instance. And what's fascinating here is how they're using the data to support artificial intelligence. Now, this is a perfect example, a third-party company, which is a Stanford-based startup called HBI Analytics. The scientists came out of Stanford, and they're a Silicon Valley company that can predict disease risks and also predict emission. And so what we did is we embed their algorithm into our software. So this is the clinical summary, which is the physician portal. And on the upper right-hand corner, you can see the patient risk. So the patient risk is around, for example, the patient's emission risk. If your goal is to reduce emission, which is expensive, you want to predict it. So they were able to predict that. They're also able to predict disease risk. For example, diabetes disease risk, heart attack disease risk, and there's a number called emergency visit disease risk, for example. When you have all these data, we make it available to a third-party company, a artificial intelligence company, to predict the risk. Then the care managers can now proactively reach out to the patient. You don't need to wait until the patient is in the emergency department or if the patient goes to see a doctor. So that became a very, very powerful thing, and that they're able to do that and to really use the data for artificial intelligence and also reduce cost. And by the way, this is a project funded by the regional government. So it's not by us, it's really by the government. So it's a fantastic project to show that. I just want to summarize my talk and by talking about, again, our company has lots of experiences really all over the world, in the developed countries and also in developing countries. I travel all over the places, certainly in Europe, in Asia, and South America. We have lots of experience in doing these projects. What I get most excited about is that I'm not a big fan of the American market-driven economy, a healthcare system. I think a national health system, you can do a lot better once you have a central policy. And also, I'm very excited about the global standards around the FHIR and IHEs, and also the emerging artificial intelligence company that can really take advantage of the data. So you really make these are fantastic tools for them to do innovation, and which can really help the government healthcare in this regard. So that's it for me. Thank you very much. I try to give back some time to you.
Пожалуйста, какие вопросы есть к докладчику?
Please, any questions to the presenter? No questions to the speaker. Thank you very much, Mr. Lee.
Следующий,
Next person to take the floor. We'll be talking about Think EHR platform as a key component of the national e-health system. Samar Novšek, product manager, Think EHR platform, Marant, Slovenia company. The floor is yours.
Hello from my side as well. Today we have seen quite a lot of really useful information, and in these afternoon sessions, what is the most common denominator of these presentations was actually separating and putting focus on data. And I believe that this is something that is going to happen in the future. So what I would like to present is Think EHR platform as a product that runs on OpenEHR, and it's proven to work in several different use cases. So we need to be aware that as a patient who goes through the several encounters in the everyday life, they generate a lot of data because they interact with GPs, pharmacy, hospital. The problem is that this data is usually stored in a proprietary data formats, proprietary standards within the hospitals. And this means that the patient data is usually limited for the patients to access it, and it's limited to access it by the healthcare professional. And at the end, it is really limited to be useful for managers, to business users, because they need to analyze the data for optimizing the healthcare system, population health monitoring solutions, diagnosing different diseases. So, what the key challenges of the e-health programs usually is when they are trying to solve these problems is that this kind of healthcare systems, modern ones, are usually unsustainable because they don't follow the trend of development new technologies. This is why it needs to look up for new business models, especially it needs to focus on the data which is vendor neutral, skip going directions to build one big monolithic solution which is not able to be flexible and agile to the needs of the end users, and especially it needs to look up in the future. So because the future will be multi-vendor, will be standard-based, and it stimulates and facilitates the ecosystem of smaller apps, fit-for-purpose apps, which are usually generated through startups and much more straightforward organizations. Marant has proven with the platform that it can manage a large amount of this data with different implementations. So this kind of settings and this kind of deployment of proper e-health system, what it can generate is it puts the patient in the center. So it's not now the healthcare providers that are centralized, but everything is surrounded by the patient. So the patient is actually the empowered stakeholder in the whole healthcare setting. With this, the clinicians usually what they have is to have an entire health history of the patient in one single repository. All the data that is available in a common data layer, it's then available for the healthcare administrators and business users to prepare a new systems and structural reforms, to prepare optimum resource utilization, and for future access of provide healthcare services to different users. And what is also, it needs to focus and it would also be a good advantage for the Belarus is to focus on local economy, stimulate local economy so that the applications that can be built on top of this common data layer can be then also exposed widely and globally into the world. Now, I said that you should focus more on a modular-based approach, not monolithic. This is, let's say, an ERP, how it evolved. In the late 90s, there was all about best-of-breed integrated system, best-of-breed applications, best-of-breed systems in the ERP world. Then, in the second stage, let's say, until 2014, everybody was talking about SAP, Navision, large integrated ERP suites, which were actually not flexible. What happened after 2015, there's a lot of new innovative applications that have been built around this ERP suite. We are talking about HubSpot, we are talking about Salesforce, which are much more fit for purpose apps built around the core systems. We believe that the same will happen on the healthcare domain. On the left side, you can see the typical scenario in the hospital. What will happen is that it will aggregate on the national, regional level, the data level, and it will be building up an ecosystem of applications on top. So how to actually move this on the national level, on the e-health system is, this is, let's say, a high-level overview how it should be set up. You need to, the best way approach to be taken is multi-vendor, multi-applicational, having a core infrastructure layer, then provide different kind of services layer and representational layer in front. This is an image and a high-level architecture deployed in Slovenia, one of the deployments of ThinkEHR platform, where it runs on IHE for document-based exchange, document-based repository, and OpenEHR for structured clinical information. On top of this data layer, the ministry runs different kind of services like e-referral, patient summary, e-prescribing, clinical registries, which are integrated via the API towards the front-end part or to the healthcare applications in the hospitals. What you should focus on where we are setting up and deploying the infrastructure, the focus should be also on open platform to provide. Many of us actually are talking about this open approach, and there are really a lot of common points of working. So we should be discussing about open service models, so it's not proprietary, then it's not preventing vendor lock-in. It's all about open information models, so everybody can access it. It's not proprietary definition of the data structure. And what it should be also interesting for the hospitals, for the governments, is to provide open system specifications. So every single further procurement, every single further development will be built on top of one commonly understandable and non-proprietary specification of the data. ThinkEHR platform, as a solution for this approach, runs on top of OpenEHR. It has been presented today as a, let's say, widely adopted specification. I can say it's not a standard, but it's like the IHE. It's industry adopted specification, which is now heavily in use in Nordic countries, going to be much further used in Europe. Germany is now going towards that direction, UK, and it all defines the separation of content and technology and provides a specification for flexible e-health systems. I don't want to go into the details about the structure because it's all about the key building blocks of the OpenEHR specification. So the archetype as a core maximum data set which is defined. This is an example of, let's say, blood pressure, which defines the all key data element that should be used for storing blood pressure data. And then we can have a template on the second level, which is a presentation of a specific use case, how the archetypes as a building blocks can be used in a different constraint level for a specific use of the case. Now, the ThinkEHR platform as our Marant core product that we are offering globally actually address all the needs from this open system, and we summarized our key capabilities in 3 words. Integrate, where when we integrate with different standards to normalize the data is stored in an open, vendor-neutral, non-proprietary data format, uses OpenEHR, and what is interesting for the future, it enables ecosystem and vendors to innovate. The platform capabilities as such for national e-health systems are actually focused on these 5 key attributes. So it's all about capturing the data from different disparate data sources, having data stored in centralized or federated normalized manner improves decision making, because now the clinicians can actually query the data because they have it stored in one single structure. It provides the ability of deliver next generation applications, and for such reason you can then set up a modular ecosystem based environment, and especially what is even much greater value, it provides powerful research capability, because having a lot of data stored in one single repository gives you a great power to innovate, to research, to get new knowledge, to get new procedures, to optimize the healthcare setting as it is. The platform as such provides different integration possibilities. As I said earlier, it's all about integration. We provide a different set of APIs. We can also integrate with an IHE environment and provide different adapters to collect the data from different disparate data sources. As such, the proposed solution actually enables you to integrate health information on a national level, so it provides the interoperability. It enables clinicians and the patients to have a secure access and exchange of clinical information, shares the core data set or full-blown EHR system, answer different kind of population questions, simple ones like how many patients have been diagnosed with the diabetes, how many patients are regularly immunized, or different other capabilities which were actually explained in the previous presentation from my colleague, and to facilitate the building of ecosystem of apps. I would like to explain 2 cases where ThinkEHR platform has proven to actually work. One of them is in Moscow, and the other one is the backbone capabilities in Slovenia. Similar approach, but with some tiny little differences. OpenEHR was considering how to set up the new digitalized way of providing the healthcare services. So they were all either leave it to all the hospitals, build up their own systems and integrate it, but it was a challenge for them. So they have decided that they would like to centralize the data in a structured centralized repository and then build different kind of applications on top of it. In Slovenia, it was a little bit different approach because it was not a fully greenfield environment. Hospitals and healthcare providers already had systems in place, so it was all about integrating the data and providing a shared care record on a national level. And what we did is to facilitate IHE and OpenEHR together to prove it and to work it in this different kind of environment. So just to show the capabilities of IHE going standardized way, and especially in Slovenia, what we managed is to set up the system in 6 months' time. It was 4 months' time taken to deploy an IHE XDS environment to exchange the PDF documents, the unstructured documents via the XDS structure, and then in the second 2 months of the project, we actually provided the capabilities of sharing structured clinical information using OpenEHR format to support it. What is interesting to show is the high-level architecture in Slovenia. So what you can see here is that multi-vendor approach on a common data layer on the bottom layer. So it was built on structured clinical information documents as IHE, which this data is enhanced with the master patient index, terminology services, and roles and privileges provided by the other vendors. And then we have patient and clinician-facing applications on one side using the API and communicate. We believe that this multi-vendor environment, modular-based approach is the best answer to the needs of the healthcare systems. Because in this case, what you can then say, you are not bounded to a specific technology, and you reduce the risk of a vendor lock-in. What is also possible with this kind of approach is the scalability and sustainability. Because going big bang with one big monolithic solution at one hand, usually it fails. So a lot of projects we have faced, they were going big bang, they stopped basically in the middle because they have seen they cannot reach the goals that they have achieved. So most of these projects went slowly, scalably, start with one single application and store it on one common data layer. With using the standards, you reduce the integration complexity, you facilitate innovation, and then what is also important, using the Open EHR, it involves the clinicians to take active part on defining what are the key clinical concepts that can be deployed.
Спасибо за ваш доклад. Нам как вот
Sama, thank you very much for your presentation. We as a country that recently got to the creation of a digital healthcare system, it is very valuable to leverage your experience, to leverage the expertise of Moran company that you have accumulated in various companies, in various countries, plus the principle as at large, digital healthcare based on open standards, no monolithic solutions, going modular, going multi-vendor. So this experience will be indeed very valuable. Thank you very much for your presentation. Are there going to be any questions on the part of the colleagues in the audience? Seems to be none. Thank you very much for your presentation. Right. So the next presentation will be about the experience of the creation of all Russian unified information system of healthcare in Russia. Ina Ashembrenna, Bars Group, Deputy Director for Development. Thank you very much, everyone, those people who have stayed here until this point. Thank you very much. I am indeed Deputy Director for Development of Bars Group. Bars Group is part of the Rostech cluster. We are working with our National Center for Informatization to create this project. It is clear that we are not dealing with everything across the board, but we do have some serious experience, some serious expertise behind our belt. So how do we get there? I've been listening to these presentations. People were talking about physicists and poets. Which is better, centralized or decentralized solutions? Which is better? So this is indeed a very tricky situation. Every authority, every subject of the Russian Federation in our case makes a decision for themselves. Let me talk about the lengthy history of us along this path. This is indeed a process that started back in 2010. Well, we are in the paradigm of the healthcare modernization initiative. It allowed for, in a free mode, there were 85 or 83 subjects of Russian Federation, entities of Russian Federation. They were creating their own intra-entity information systems that were supposed to be somehow implemented into a shared system in a federal level. There were no stringent requirements. The requirements were very flexible. What did it result in? Nothing good came out of it. These are the issues that the current healthcare authorities are improving. So there's been a new impetus in development, the so-called digital disparity. Digital disparity in terms of various subjects of the Russian Federation did not go forward and did not reach the KPIs as planned. If you consider that there was a Rostech company that started developing a centralized system by a single vendor. At the same time, the constituencies, the federal subjects, were running their own tenders according to the state tendering legislation. So everything started with the infrastructure things. So we have building, we have premises, we have medical institutions and organizations, we have medical people that need to be clearly recorded, clearly monitored, what they're doing, why they're doing, how well they're doing it, and in what capacity. Some resource gauging scenarios. So we needed to look at the affordability of the resources, whether it's available or not. So if the colleague, well, like the colleague said, there must be an opportunity to reach an inpatient department or some hospital, and other paramedics and the doctors there qualified enough to render some kind of specialized assistance. So we decided that some new managerial decisions will need to be taken. This is how we created a single registry of federal registry of medical workers and medical institutions. So what else are we using this for? The medical registry, medical HCP's registry is not just something that we decided to do for the sake of doing it. It's ongoing medical education. It's ongoing development for paramedics and doctors. This is not just about the certificates or certification. It's also about further educational needs, further demands, some continuous information flow that are critical for every medical domain out there. Now, looking on current days, so I'm wrapping out my historical bit, we've adopted the National Healthcare Development State Initiative that is designed to run until 2025. It was also dealing with some very important points, and we realized that we need to bring the status quo of this current situation to some order. The powers that be deserve a thank you for making some key things happen. So let me show you. Two pieces of legislation have been adopted. The first piece of legislation is about the fact that there is IT as a building block, as a full-fledged component, similar to doctors, similar to medical equipment and so on. IT is a full-fledged component of information systems. And in 2017, in 2018, there was another resolution by the government, number 555, saying that this system is unified state information system in healthcare. All third parties must connect to it, all the hospitals, all healthcare institutions as well. Not just in their own environment, but in the country as a whole. So let me bring you back to this slide. A huge block emerges here. It's a national project. The colleague were mentioning about this. So digitization per se is not exactly lucrative to anybody. The national project called Healthcare until 2024 that was launched this year. I will talk about that later on, the digital counter. I'm not a Ministry of Healthcare representative. I will talk about how we as developers are affected by all these considerations. According to the fact that the national projects, national initiatives are now geared towards mortality reduction, neonatal maternity reduction, oncological mortality, cardiovascular diseases mortality, preventative work, so to rule out all these bad things, to stop them from happening. So these are the ones that the Digital Conta project it's what it's all about. Initiated in 2019. So let me tell you what the harmonized state information system is like, or unified state information system. It's an iterative process. There are conversations about something good, something bad. Some things will become obsolete and will basically fall off, but the other blocks will be developing. So once again, the resource block, federal registries of HCPs and medical institutions, with everything in there. Then the national directory, information directory, plus the information analysis system for healthcare, for pharmaceuticals. There is ongoing modernization and replenishment of these directories for pharmaceuticals, for example, the one I've just mentioned. It's a very big block in terms of provision of various pharmaceuticals to all strata of the population. According to other registries, I will go on to talk about that later. Federal digital appointment office, affordability of care. This is a versatile tool of today. All the colleagues that spoke before me and the ones that are going to come after me, they will tell you that this is something we have in Russia. This is something that people are getting used to. And the federal hospitals are already maintaining this, are already using this. They have this ways to issue tickets to make sure people make it to the appointments. So I'll talk about nosological registries. We have always looked at that when doing our economy, when funding and budgeting. It's the amount of assistance and pharmaceuticals that are needed to maintain or to treat the patients. The nosological registries, as they exist, are fine-tuned, well-made systems. However, they are not fully based on the primary data. They are aggregate, or they are based on aggregated, controlled, clearly monitored, clearly audited tools. I will tell you the path that we've taken along this, for this direction, and the integrated electronic health record. This electronic health record has been around for quite some time. We've been dealing with this for 4 years now, together with Informatization Center and Rostech for some blocks. Before that used to be Rostelecom and other companies that were part of this effort. The paradigms changed, the approaches changed. Currently, over 54 patient histories have already been accumulated in the digital format. The validity of these documents, the accuracy of information is quite low, but this is something we need to start from. The integrated electronic health record must include everything that is happening to the patient in the country now. Our institute has taken a long way to make it happen, our institution. But the Ministry of Healthcare said or decided that this will be this so-called registry of electronic medical documents. This will be the sole purpose of this repository. Querying and cross-querying the resource where the original sits. So at all times we can cross-query the document and file this information to the patient's personal office. So it's a very big system. I won't dwell too much on it. Many organizations, many stakeholders involved. The components have already been mentioned by myself. We were part of the creation of these. Nosological registries come in many flavors in the country as of today, and they are kind of inherited. They migrated to a new platform. 7 nosologists, 7 high-cost nosologists, used to be 7, now there's 12. All kinds of narrow TB, HIV, Parkinson's, low-weight babies, and so on, low birth weight babies, and so on. So what I'm saying is the paradigm is sufficient to make it happen, for it to take shape. I'll just skip this. So in principle, there is a personal office that I mentioned, the virtual personal office that Belarus is striving for, and we are also preparing towards it. I believe that Russia features one of the best personal offices for a citizen in terms of convenience. Having visited many countries, I realized that the personal office that the Ministry of Communication and Ministry of Communications has created, interdepartmental cooperation in mind, it has become a very powerful tool. One of the blocks is healthcare, where appointments can be made. It's all planned according to the roadmap. Dispensarization, patients concerned about their health, so there will be a lot of key elements that the Ministry of Healthcare cares about. So everybody will be working in this single electronic medical document system. Telemedicine system at federal level is developing at a very high rate, at a very high pace. We're also part of this process. We're creating it. We're part of its creation. So let me tell you in a nutshell what this national project is and healthcare project, national project. It's a very serious amount, 178 billion Russian rubles. It will run until 2024, but it's more than that. Within it, it's a federal project with sub-projects: primary medical sanitary assistance, federal project to combat cardiovascular diseases, oncological diseases, child aid, federal project, how do I put this, or some tourism related or whatever. So unfortunately, it's not my topic, so I won't talk about it too much. The digital counter is the most important. It will unite all the profile things into a harmonized system by various actors, various ways of implementation. However, it will all run through a federal system, a harmonized federal system. What's it going to be like? So, and what are we progressing towards today? The country is big, 85 constituencies or subjects of the federation. So everybody is making a decision, cloud-based or internal in-house solution. We as BARS group, we are working on centralized solutions. It's a big size, big scale cloud, which is installed once and for all, and it's used by all the institutions in the federal entity, in the federal subject where we deployed it. 10 of them have been already processed. 10 federal regions, federal subjects have been worked on, have been deployed. The costs are being cut insanely. The harmonized process would mean lack of accountability, you would think, unless there is political will and there is an understanding at the federal level and the constituency level. Because thank God, these institutions are doing much better than they used to. They were trying to buy in-house systems or system for in-house use before by themselves. We don't have to do that anymore. We have harmonized identification procedure, lab testing results, centralized. Various organizations, various entities can hook up to the system. And it's so flexible that it allows for a very efficient coexistence for this entire paradigm. So at the level of federal subjects, it's centralized. It's centralized. At the level of federation, this is not the way to go. This is about integrated systems. It's about interaction and interoperability. Integrated health record is a tool for integration. Therefore, we are undergoing a new spiral, the developmental stage. The subjects of the Russian Federation will receive the funds to make sure that the results are compliant with the requirements. The Ministry of Healthcare provided those requirements, and the requirements to the medical system, at least the top tier, the federal level, plus some requirements for the regional segment, the so-called subjects or federal subjects medical information system. And the subjects, the federal subjects, are supposed to align it, to bring it to the common denominator. They can do it in a centralized way. They can do it themselves through APIs, through buses, and so on. So I will tell you that there is a change of approach. It's process-based models. I wanted to talk about that briefly. As of 2008, I myself was handling implementation of monitoring systems. So it's not just monitoring of control, monitoring of implementation. It's monitoring of patient management. It's not points, it's the continuity. We started doing it from deliveries, from childbirths. When we implemented that in the first federal subject, the neonatal mortality has gone down by several %. Why? Because the centralized system allowed for the doctors to see where the patient is, what's happening to that patient about to deliver, the pregnant woman, and to compare what would be the benchmarks, what is supposed to be happening at the next stage, and what kind of parameters should the patient exhibit at a later stage, and does it correlate with reality? So yes, there are some ways to implement that in the Russian Federation. There are some professional debates going on around that. But there is a tool, and we've made a bet on the Order 555, and we are making sure that everything is done in very tight requirements of the law. When the patients are being taken care of in the short time frame, it's perfect. The colleague is already not there who was talking about medical errors. This is indeed a very valid point he said. It's not about punishment, quality assurance. It's not about punishment. There's so much workload on the doctors that they cannot think about the next step every step of the way. The systems are supposed to help them, to assist them in making the next step. And if something happened or something failed to happen, there should be a notification or reminder to the doctor by the system to avoid these medical errors in the first place. So there are cases where the budget money were not even used to buy this sort of systems. The hospitals went for it themselves. And most importantly, vertically integrated medical systems is the new paradigm, the new approach that has been introduced recently, and it's part of the new national project. These are the stages of patient management for every narrow medical profile. Like take an oncological patient. He's being serviced by a whole number of medical institutions. Primary diagnostics here, treatment here, rehabilitation here. So who and in what way are controlling this? Where and who? Everything should be done accordingly. Who checked that? It's not just about the treatment process, it's also patient management. Do patient management. So vertically integrated medical systems that are going to receive as uploads clinical information. It's not information system at the level of the country. So this will be a clinical system, a clinical information system to be monitored online for any deviations, for any discrepancies from the preset indicators, clinical indicators. Good or bad clinical indicators, the expert community will resolve that. So what I'm saying is we're creating a new approach in working with the data, in working with the patient. The patient becomes the center of this paradigm, and the information trail is following. So you might have seen here that there is another element emerging. According to the disposition of 2017, there was a reversion. We reverted to ex-USSR experience. Back in the days, back in the USSR days, there were think tanks, there were oncological, cardiovascular institutions that were gaining expertise, endocrinological think tanks, reference centers. So this kind of reference centers must be implemented across the country. Because we have around 100, 200 of these institutions. We need to align them properly with special passports of these services. And there must be some tools to help them progress along this way. So you also see some genomics, genetics there. Switching to personalized medicine is announced by everyone. Every country is talking and screaming about that. We're very friendly with the WHO. WHO preaches this approach as the paramount one. This is indeed the case. Our country has also announced that, and we're gradually shifting towards it. Personalized approach to diagnostics and treatment has already been announced. Since design team are IT people, we're not medical healthcare. We have the Gene Expert product that helps increase the level of data protection, provide the information in a formalized way, protected through such stringent data protection standards. Our experts have done unique bit of work, which has not yet been performed in the country. They have formalized all the syndromes, all the ways to differentiate diagnostics of various genetic diseases based on the genomic data, based on various genomic mutations. So we have this Gene Expert product that is going to become one of the building blocks of the big information system in healthcare. So briefly, there are many iterations. It's a lengthy path, many mistakes along the way. At the same time, we realize that Belarus is quite well off. You can learn on the mistakes of your neighboring countries. There are other countries which are not exactly neighbors. The UK with some adverse experiences. Swedish experience is much better. There is Russia with a very rich experience behind its belt. So we're prepared to share this experience, this expertise, and we're prepared to help you avoid the avoidable mistakes. So that's it in a nutshell for my part. Thank you. Any questions, please fire away. Thank you, Inna, for the presentation. There seems to be a question. Magnificent presentation. Thank you very much. I have a question, though. In Belarus, cardiovascular diseases are #1 in mortality risk. Well, that's pretty much across the world. So trust me when I say it's not just Russia. Okay, it's not just Belarus. So I'm an economist, so I'll be asking about money. Could you please tell me on a specific case? So you have 450 to reduce the mortality by 450 people per 100,000 population. So it's not us, it's the Ministry of Healthcare. Yes. So what are you doing in the healthcare segment? Okay, so I'll tell you about that. It's the same story with OBGYN, obstetric gynecology. The equipment is a major bit of cost. Overhauling of buildings and premises, training of staff. We need to upbring the staff, right? We need to educate them. We come up with the new paradigms, new methods of servicing. So the money is being spent, but the effect is far from being as desired. So what can information systems do for us? The information systems are impartial. They will be impartially taking in the information from various systems, and they will help control and audit. They will notify the HCPs, they will notify them of the deviations. The right person will get the right notification, or the right authority, the right institution, or the patient will get the relevant notification. So let me get back to this project with the management of pregnant women. So she got registered as a pregnant woman, and she started moving across the country. But what do we want as a country? We want a healthy mom and a healthy kid. So we have ultrasound here, we have the doctor here. However, if she moved, well, is there any way to control or to follow up whether ultrasound checkups have been made or not? And then when she comes to the maternity hospital at the end of her journey, and we are missing out on this information, it's a very bad thing. So it's critical to understand what is going on to a person at every step of the way, across in time, continuously. Cardiovascular, it's all about prevention. It's all about risk calculation. It's all about showcasing these risks. It's all the case that you're fully. It's a very valid point. So we can summarize the information about various pathologies, and we can make prognoses for patients, especially with some adverse findings. We can even call up a patient and say, like, or not even call, but in a virtual or private office, dispensarization tomorrow. Please go there. Please make sure you're safe. Your healthcare is protected. Your health is protected. The doctor, when receiving a patient, might have a patient without physical manifestations necessarily, but he will have a risk profile that will help pre-guess or predetermine that this patient is prone to this disease or condition. Evgeny said something here. The process of patient management. We're giving this virtual private office. The person is working with that private office. We're giving them the wearables, bracelets, whatever. It doesn't really matter. The blood pressure measuring devices, BPMs. So the system is looking at this. You know the workload on our doctors. How are they going to respond? So this is where the system kicks in. The supervisors or the attending physicians are telling either the patient or the physician, you have a potential disaster coming, or the potential complications coming. So this system is one of the pillars of the information field, information environment. It's additional control. It's an additional level of checks and controls. Plus, additionally, we're creating an additional block where it's not just going to be about paperwork. You know that dealing with the order on deliveries or childbirth, this order is hundreds of pages thick. Same for cardiovascular disease, 196 pages. I might have misreferred the patient, or I did not refer them to the vascular center. So there was no way of even trying to treat the patient here locally without the proper facilities. He or she should have been sent to the regional level, the regional center. Thank you very much indeed. Unless there are any further questions, I'd like to give the floor to the next presenter. Next speaker to take the floor is Andrei Dukov, Deputy Head of Sales and Development, Netrica Company. He's in charge of healthcare division, practice of construction of highly loaded information systems for state healthcare. A request to all the future speakers, please make sure you observe your time limit, because we're behind schedule already. Maybe one or two questions tops from the audience, so that those who speak last would have some time, enough time. Okay, please, can you tell me if I'm exhausting my time limit, if I get too excited? Okay, I just wanted to share our practice. Fortunately, in the Russian Federation, this model took shape where we have the federal level, the federation. And the federation gives us certain liberties regionally. Our regional processes are for us to take care of, the subjects of the federation level, the way we see fit. Every region would have their own medical budget, healthcare budget. For this reason, every region seems to be taking every decision themselves, and they are responsible for this process themselves. So how did it affect us as a vendor? Or how did it impact us as a vendor? We are advocates of integrative approach. It was born in St. Petersburg back in the day, and thanks to us, in part, we were part of this picture, it was replicated to 16 subjects of the Russian Federation, 16 constituencies. There are quite big ones, like Krasnodar Krai, St. Petersburg. Krasnodar, both are 5+ million people. There are some smaller subjects. However, the point is, I can clearly see it, how it's running through us. We are a company that is dealing and preaching this integrative approach, and we sit down and we talk to every constituency. St. Petersburg is big, it's powerful, it's kind of a trendsetter, it's a pacemaker, it's not letting us fall asleep. But with other regions, it's very important for us. It's very important for those regions. It's very important for St. Petersburg, ultimately, that the experience, the expertise that we generate must be critically processed and replicated to other regions, other constituencies. We got lucky in 2014 for the second time when we faced, or when we started working with the fire standard. Because the expertise, the openness of the standard, it enables us. We do not have thousands of analysts as a resource. This standard already has thousands of analysts working on it, processing it, digesting it, and giving us a very good standard. So we are simply picking the block that we want to deal with right now. It's no longer this huge database. We are very focused, and we apply something that we're focused on right now. So this application strategy is very interesting from the practical implementation viewpoint. So this resource, plus it's amazing. I mean, the version 4 of Fire has been approved. If you decide to take on Fire today, you'll be even more lucky. You'll be even luckier, because it's backward compatibility from V4. So right now we're having some issues with backward compatibility. My colleagues are aware what I'm talking about. So somewhere V2 was deployed, V3, so we will need to align that. We will need to align that proceeding from V4 as a common denominator. Although it's quite tough, because St. Petersburg is 15 experts, or 15, information systems, 15 development paradigms. So we need to somehow take on this train of 15 train cars to help to make sure it keeps up with the V4 transition period. So we have this conviction, we have this idea, and it's backed up by Fire community, that this is the final major iteration. Honestly, they gave us a heads up before V4 was adopted. So yes, we knew we had it coming. So at least psychologically we were prepared to see the new iteration. Now, accordingly, there's been an interesting period in our history back in 2010 for St. Petersburg. We had a medical information system back then, and there was an idea that possibly us, the people who recently joined this picture, maybe we can make it better, we can do a better job than the experts who have been dealing this for 1 or 2 decades. Well, definitely this is not the case. Fortunately, we were allocated a separated but big amount of work to integrate this standalone information systems into something one, into something harmonized. Belarus is well off in this respect. You already have a very well established, and I believe I had an opportunity to meet the guys. You do have a high level of informatization at medical institutions. I've seen things that inspired me. I've seen medical information systems that are in operation. So back then I made an observation. It's even deeper than in St. Petersburg or in some regions. It's a more elaborate directory, like a directory of doctors' summons. 32 city polyclinic in Minsk has developed it, and they are providing it to the patients. The patients can use it in their day-to-day routine. So we even requested a copy of it to see how it's done. So what I'm saying is Belarus has already some very good starting point. And to us, as preachers of integrative approach, it matters for us to ensure taking on this well-established medical level and use it, because we don't have the objective to tell you how to informatize, how to make your information technology better or more digital. You guys have been doing this for a decade or even more, so we cannot really tell you how it's done. But when we're coming to a new region, they might have several medical information systems in place. When we come with our components, with our basic components, we provide these to them, and we see there is no template approach for various regions. Some countries are starting with something else than the others, and if we see that this integrated health record, electronic health record, is the first step for this region, we are giving it to them, and we see how they evolve. We give them the protocols and mechanisms, and we see some evolution on their side when they're implementing this. The intricate value for the Russian Federation's subjects is not just about us coming, installing some database. Okay, the database has been deployed, you guys are doing fine, and we're off. This is not the case. They are working with this local competencies, local capacity building. They are working with this international standard. They are using these protocols, information interaction, specialized, REST, and so on. So they are taking in these competencies. They are imbibing these, and well, we are mortal people, things can happen, but still, these times are continuous, and they're there to stay, even if we come and go. So let me skip these points. They have been discussed at length multiple times. Difference in approaches and so on. Yes, there is difference of approach. It's been clearly described already. What we are doing is we're working at the regional level, and we help, using us as intermediaries, we help interact. We provide interaction interface for these medical systems, for other departments as well. It's not always the case that it's integrated out of the box. There might be some integration platform that will connect the medical database to some other agency's database. For example, the region decided to install some specialized system, medically purposed system. For example, for emergency rescue, for ER teams. And they would say, like, we want to know all the information about the patient that we're sending an ambulance to. So this information can be made available from the integrated system. Or, for example, they decided to implement a system for clinical decision-making. This would be the same story. They will connect the SPPVR system to our platform, using us as intermediaries. Again, there will be exchange of data to and from the database. They will receive the notification whether it's correct or not, according to SPPVR at hand. So we have identified and we have developed microservice infrastructure. What does it refer to? We have standalone components, which we've tested on 16 regions, and we see that, for example, this process, service of appointments, proxy structure is ideal for it. We've seen it in one region, we replicate it to all the others. With the appointment service, we got lucky anyway. The analysts thought about this for a while, and they identified this approach as the correct one, so we got lucky. Other regions have not progressed that well. There are some common databases that they try to cross-reference, and there are collisions in this cross-referencing. What does it mean? For example, a senior citizen, grandmother sees some ticket is available, but she cannot make an appointment to that ticket time slot. So to us, it's a technical collision. To her, it's cheating, and she starts to call the president sometimes, the hotline with the president. This is when things get down to the executional branch of power and so on, the doers, the actors. So everybody gets punished because of some common collision. So it's a living structure that lives and breathes, we see it. Also, there is a way to exchange the lab testing data. When we first ran it, we took an open platform. We saw it's built on Fire. We grew it to a certain stage of the pilot projects, but we can, once we try to cross this pilot operation stage, we cannot. We were limited by the pilot operation frame. So we try to change the project. Again, some ceiling, maybe a bit higher, but it took us 3 attempts to rewrite the service of lab testing. However, having collected this in-house expertise, this good basis to proceed from, when we're making the service for instrumental research, visualization research, we are approaching the tried and true approach from the 3rd iteration from the previous project phase. And we see that a lot of information is being handled. This 3rd attempt for the laboratory testing was the first successful attempt for this next stage of our system. The patient must remain key at all times. We must never forget about the patient. Our objective, since our client is an organizer, with the managers, decision makers in healthcare, I try to proceed from the analytics. I try to proceed from the analytical things that the organizers want to see. For example, there is a suspicion, or that there is a suspicion on oncological disease in some patient. If it's a rank and file case, we will see 10, 15 iterations of medical services provided to that patient. If we centralize it around the patient, then we clearly realize that there is only one patient and not 15 isolated individuals, 15 different individuals. For us, as an agency that is in charge of healthcare management, it's a very different sort of information. It's a very different set of principles to proceed from initially. So we never neglect that. Going back to the quality of data and working with the data. Finally, we've approached this. We were very careful about it. Our clients were also very meticulous about it in terms of how the data is given to the patients. Well, sometimes the statistics is much higher. It's off. You can see some features on TV that deal with that. But it's a very bad thing because we miss out on the proper picture, on the actual situation that's happening in our healthcare. So by opening more and more data in these virtual private offices of all sorts, we are purging this, we are clearing this data through crowdsourcing, through patients who complain, who see stuff that's not supposed to be there. Definitely these complaints need to be processed, but for us as IT people, it's highly critical. Because this is the way the users of the data, the consumers of the data, provide feedback. Once you've put the system in operation, both the patients and the doctors and the HCPs will need to look at what's happening and take measures when it's not happening as it should. So there are some analytical cross-references or cross-sections that we see in the platform. Definitely, these are the components of this integrated EHR. This iEHR is an aggregator of all the data around the patient. We were also building it up incrementally. There was a stage when we just contemplated as some sort of entity, some sort of structures. Now we are thinking about it more, about this net information. About the information, additional data, such as medical records, medical documents, which are supposed to be included here as well. And we want to build the analytics proceeding from it. We want to understand what's happening in our backyard, so to speak. The provision of data for the doctors and provision of data, providing the doctors for the patients and for the HCPs, we realize that there must be some system of access control. SAC, 50,000 HCPs, right, in St. Petersburg. You've given 30,000 doctors in St. Petersburg alone. So clearly, managing this sort of data in a non-centralized manner is impossible. So for this reason, we've developed a system of access control with multiple sources, multiple verifying sources, the registry of HCPs, the medical institution region that they are filing a reference query from.
Именно через систему управления данных.
Through the system of data management, we have various valid information sources. Patient index is also an important bit. Because of the fact that we're patient-centric in this, it's very important to have the opportunity to integrate with some primary content. I don't know, there is a Ministry of the Interior database, Internal Affairs. So you can build a patient index proceeding from that base. Because for the majority of the regions, this Ministry of the Interior calculated index is used as a probability criterion. Sometimes there are some bodies and agencies that want to maintain this sort of statistics, and it's valuable for us because it will be more data purging, more better data ultimately. Bad data gets purged for us and for the healthcare managers ultimately. More valid data for the HCPs, for the managers, and for the patient themselves, for the patients themselves. I've talked about the laboratory project, laboratory testing, appointment line management. It's a very interesting add-on to this appointment management. Referral can be used from the city portal to manage these lines of patients. Plus some additional services are coming, which are critical to the managing authorities in the healthcare domain. Our integrated processes, our integrated projects are quite complex. So we've gone through, we've analyzed a number of tools that will reduce this complexity by bringing everyone to the table, the client, the medical information systems, developers, everything. So we are encouraging to manage medical information. We are encouraging to create task forces and working groups which are going to be operating in the regions, taking on this huge workload. For the analysis, clearly, the level of detail and level of validity of analytical data is very critical for the process, for the platform's operation at large. This is the primary data that we're supposed to harvest. We cannot eat the entire elephant at once. We need to split it in chunks. So the focus of analytics helps us identify more specifically the priorities. This is a big process. Integration of medical integrated systems. It's a stage-wise, incremental process. So we are focusing on something specific at various stages across along the project. So this is a big amount of data, a big layer that used to be hours and hours alone, where we're monitoring medical information systems. Now these MISs have become mature enough in many regions. We've given these tools into their hands, we've put these tools into their hands, they see their own mistakes and they're thankful for it. They want better data to be provided from them, and many are already linked rigidly to this platform. And they realize that if they go to another hospital, they will see this data in a much better way, so in a much more complex environment. So these are the medical systems at hand. This is a kind of a trio. It's not just about vendor's platform operation. It's also a teamwork that matters. The client's assistance, or helping the client for this huge body of work, work with information, work with medical information systems. So these projects are indeed very interesting. These projects are very fruitful and lucrative. Thank you very much. Keeping up the good work. Thank you, Andrew. Any questions to Andrei? Doesn't seem to be any. Thank you very much for keeping up with your time limit. The next person to take the floor is Bram Kevit, the Director for Integrated Solutions for Care of Philips. He'll be talking about the experience and technologies of the creation of regional integration platforms of digital healthcare.
Well, thank you very much for the invitation to talk with you about the national e-health system for Belarus. And some of you might remember I was here last year as well, and I was really impressed by the huge progress you've made in this one time just 1 year time period. Also keeping aware of the time, I want to just present a short example of how we use technology to create such an integrated health record. I will take an example from the Netherlands. But first, I want to show you that I'm working for Philips. I'm working for Philips Forecare, the department within Philips that's solely focusing on interoperability, and we are really connecting the dots in healthcare. And we talked already a lot on this integrated electronic health record for Belarus, and there are a lot of challenges and promises made regarding to this IEHR. So to name a few of those promises, we've talked about improved efficiency. So we need to be aware of the scarce time and resources we have in healthcare, like when we talk about doctors or equipment. And the question is, can such an electronic health record really contribute to the improving efficiency? And also, one of the main drivers in healthcare has always been and will always be the improvement of the healthcare outcomes. So can an integrated record really contribute to this improvement of healthcare outcomes? And the costs as well. So such a system will also cost money. Is there a positive business case for such a system? And on the other hand, we have the challenges. Privacy and security is already meant many times today, and we're talking about real sensitive data, so this is very important. And the other systems that are already in the hospitals, the doctors, like Mr. Kogan said, the doctors want to use their own system. So there are already systems in the hospitals. How do we connect all the systems? And the scalability of such a platform. Is it really that the system you implement today, is it really ready for the future? Will it be ready for future use cases and for a really big load of use? So as suggested by a lot of my colleagues already, we suppose that you need a future-proof and standard-based interoperability platform to exchange this medical data in order to create this electronic health record. And I'm not going into the details of such a platform. There's already a lot of discussed on that topic today. I just want to show you a very practical example on how this could work and how it worked in the Netherlands, in the region of the northern region of the Netherlands. So I want to give you a brief context sketch. So in this region, there's about 1.7 million patients, so it's not the biggest region of the Netherlands, but area-wise it is like 25% of the Netherlands. And we have a lot of hospitals in there, about 10 hospitals and academic hospitals, and of course a lot of other healthcare providers. And the beauty of this region is that from the bottom up, the hospitals decided to work together and to create such a platform to create an integrated electronic health record. So it's not enforced by a governmental organization or something like that. So we started in 2009. We've implemented together with a local partner for infrastructure, because we really think that we need local partners for implementation, for infrastructure, for securing the infrastructure as well. We started in 2009 creating an IHC-based record exchange platform. And we started with low numbers, but we grew over time, not only in volume, in number of patients, but also in number of use cases and number of connected systems. So to give you an impression on how you could use such a system, I will want to present 4 use cases with you. So we use this single platform to cover all the use cases I just want to present with you. The first one is image sharing. So when they started, their ambition was to get rid of all the DVDs and these CDs that were burned and sent over by the post service between the different hospitals. Because this was time consuming, but also very costly. So nowadays, they succeeded because there is no DVD sent over the post anymore. So when a patient is referred from one hospital to another hospital, the images are immediately available for the other hospital. And also when a specialist from the academic side, for example, wants to have a look during an emergency, wants to have a look at the images, they are almost immediately available to have a look. So we achieve this by just connecting the existing systems. So the second use case I want to present is an integrated treatment plan for crisis teams in mental health care. So this psychiatrist can access 24/7 the treatment plan of a certain patient, no matter where the patient is treated. So the beauty is we use exactly the same platform, but both user groups, so for the image sharing and for the mental health, don't see the information that's meant for the other group. So only thanks to the access control, and we build it based on the open standard XACAML, only psychiatrists can see the mental health information. And whenever a patient is transferred from one hospital to another hospital, or from a hospital to a GP or to a nursing home, of course the receiving end needs to know the latest status of this patient, the latest condition. So he needs the medication, he needs to know the allergies, the procedures that were taken in the previous setting. So therefore we share patient summaries, and therefore we connect EHR systems. And another example I want to give is the proton therapy. So in this region they have this highly innovative proton therapy center. It's one of the few in the Netherlands. So from all over the Netherlands, patients are referred to this proton therapy center. And to optimize the workflow and optimize the use of this system, this quite expensive equipment, we introduced a digital referral workflow. So that really contributed to the optimizing the process in such a proton therapy center. A little bit more about how we connect all the systems and how the connectivity works. So, as I said, in the very core of our system is the IHE XDS-based sharing platform. This is highly secured because we only work according to the latest security standards, and we use our local infrastructure provider for that. So, as I said, we connected hospitals, we've connected the academic side, we will connect the GP soon, and also the patient has a very important role in this setup, and I will show you in a minute. So when we zoom into the hospital, so what I said, we have connected to a lot of hospitals, and inside such a hospital you see there are multiple systems that need to be connected, like the PACS system, the RIS system, the EHR, and they all use different standards to connect. The DICOM, for example, for the images, but the EHR, the 807 for the RIS system, for example, the XDS for example, with the EMR, and we've connected with a multitude of different vendors. Like for the EHR, we've implemented with Epic, the well-known American EHR company, but also with a lot of local EHR companies. Regarding to the PACS, we've, for example, connected with Aqua, with Cetra, and CareStream. And having a look at the patient, I want to mention two things. One is the patient consent. So in this region, there is no exchange of data without the explicit consent of the patient. So this is very important. And the other topic is the personal health app. So in the Netherlands, there are a lot of providers that offer such an app. So the patient itself can choose which kind of app they want to use to see their personal data. And what we do as the platform provider, we just provide the FHIR interface so app developers can connect to the data and show it to the patient. So we are really connecting the FHIR world with the XDS world. Of course, we also did an evaluation of the benefits of using such a platform. And when we look at the image sharing, and I'm sure we will have similar results for sharing patient summaries, for example. But when we have a look at the image sharing, we can say because the acting doctor has access to the history of the patient, the clinical history of the patient, they can make better informed decisions. And because all the history of the patient is available, we do not need to redo all the different examinations. So this saves really the exposure to radiation for the patient, to a patient. And also we improved a lot the efficiency in healthcare and in the clinical process. And I want to give you two examples. One is for radiation therapy. So before, it took about 2 weeks before the DVD with the image was delivered at the hospital, at the radiation therapy center. But nowadays they are directly available. So this saves a lot of time in the clinical process for cancer treatment. Another example is stroke emergency. It's very important for a stroke treatment that they start very soon, very fast with the treatment to save as much as possible of the brain. And we were able, with our technology, to shorten this period with 30 minutes. So this is really a high contribution to the treatment of stroke. And also, when we talk about costs, cost reduction. So when we take a look at the image sharing, we compare this with the old-fashioned DVD exchange by the post. On the left, you see how the system is increasingly used over the last couple of years. So in 4 years' time, the use of the system increased 10 times. When we have a look at the cost, so when we compare this with the DVD exchange, at the beginning, it cost about the same. So for both the exchange via XDS and the exchange by DVD, it cost about 20 euros per patient. But nowadays, it is reduced to about 2 euros. So that's about a reduction of 10 times. That's very big reduction, I think. So coming back to my first slide, we talked about the different topics, and the question was, could such a future-proof and standard-based interoperability platform really help to meet these promises and to deal with these challenges? And I think I've shown you that yes, indeed, we did work on efficiency. We improved the outcomes. We lowered the cost. We took care of patient privacy and security of the data. We connected the different systems, the existing systems in the region, and we proved to be scalable, looking at the different use cases we support. So there's one last thing I want to show, and I want to share with you. So because the use of open standards is really at the core of our solutions, we don't say we are just vendor neutral. We like to say we are multi-vendor positive. And this is also an invitation to our colleagues. They might be competitors, but I like to call them friends, and invite them to work together to create this integrated electronic health record. Thank you very much.
Спасибо. Какие вопросы?
Thank you very much. Would there be any questions?
Thank you very much for a very interesting report. Can you please tell us how do you make this when some doctor make a consultancy on the image, how do you make it legal? Is it some signature, electronic signature, or something like this?
Yes, so what they do, that's just the way they used to work nowadays, or before they used the system. They indeed confirm, like in the report, they say that this is like in their reporting system, they mention that this is their.
So no signature, just document.
Just a document, yeah. True.
Oh, thank you.
But of course, there are a couple of opportunities to add such a signature in such a solution as well. We can talk about it if it's relevant.
Брам, спасибо.
Thank you very much, Bram. The concluding presentation for today will be delivered by Tatiana Puchenya, Head of Regional Sales in the Republic of Belarus, Gettinge company. She'll be talking about international experience of implementing Gettinge solutions in Belarus. Good afternoon, dear audience, esteemed members of the Presidium. Thank you very much to all the last people sitting rather than standing. I will try to be brief. Once again, I'm Tatiana Puchenya. I'm the representative of Gettinge manufacturer. So it's a quite big international player that is supplying medical equipment, disposables. I would like to thank the organizers for the opportunity to take the floor here. My presentation will be somewhat different from our habitual image. I would like to talk about the digital solutions that our company provides. This is not typical for our markets. However, I see that the road to digitization, going digital, has already been paved in Belarus. So please let me introduce our solution. So in a nutshell, I will introduce the company, what we're about and what the company is famous for. Being a partner of major institutions, Gettinge is also helping resolve various healthcare-related tasks and objectives, which are being tackled by a multitude of healthcare institutions today. It is helping through digital solutions by and developed and implemented by Gettinge. Clinical logistics, patient's insight, a system of insight system, clinical information system, toolkit flow, disposable flow in sterilization, TDOC system. Integrated OR Tegris. Closer to the end of my presentation, I would like to try and convince you that e-healthcare is supposed to happen, and it will happen regardless of the investment costs implications. So, coming back to the Gettinge as a company. The company has been around since 1838. It's operating in over 40 countries of the world, so it's representative offices. Well, yes, rep offices are in 40 countries of the world. The sales are happening in 160 plus countries of the world. The company staff is 15,500. The factories are scattered pretty much across all the continents in 10 countries of the world. Eurasia, America, Latin America, particularly. Just Africa and Australia are still the white spots for us. The company is known for the supplies of surgical equipment, medical devices, equipment for anesthesiology and ICU, wards, sterilization, turnkey solutions for sterilization departments. Yes, please use this other microphone. Yes, thank you. You can hear me much better. Much better. Okay, you should have told it before. Well, the interpreter could hear it somehow. Right, so Makev company, which is part of Gettinge Concern, a group of companies, is the world's only integrator who is providing turnkey hybrid ORs. We have recently realized the number 1,000 projects for hybrid ORs in the world. Gettinge company can say that about themselves. I represent the Moscow office, and we are in charge of former Soviet Union countries, also some part of them, Russia, Belarus, Kazakhstan, and Armenia, 4 of them. We have also acquired a lot of expertise in implementing this sort of projects. Over 130 turnkey projects for ORs, for ICU wards, and stations for sterilization. However, facing contemporary challenges that big clinics are confronted with, they are quite clear for the Belarusian conditions. They are the same in Russia, pretty much. Everybody is talking about it. Everybody is striving to reduce the hospital stay, to reduce rehospitalization rates, the cancelled surgeries, the undergone surgeries, to reduce intra-hospital infections, the waiting list, the risk profile, mitigation, and so on, for the personnel and for the patients. The majority of clinics are also thinking about boosting the efficiency of OR use, the utility, the bandwidth of the inpatient departments, to boost the safety and security of the patients, their satisfaction with the level of health care that they receive. And we cannot but notice here that more and more clinics, more and more countries come to the same conclusion. They arrive at the conclusion that extensive growth is no longer possible. It's no longer possible to see an increasing patient flow, people's flow, with the current or even lower budget cuts, lower amount of budget cuts. It's impossible to extensively grow the number of, increase the number of ORs. The only way to go is to use more efficiently what's available now. And the practice goes to show us that only digital solutions can help get there. Currently, Getting as a company has a suite of software products that help clinics around the world implement these solutions and resolve their objectives. First of all, it's the patient logistics insight management system, integrated OR Tegris system, and the TDOC turnover of materials and equipment through the centralized sterilization department. According to the American data, the USA people are very fond of doing the math. Approximately 1/3 of inpatient department resources are not used efficiently. The digital solutions are helping with this, and we're very happy to be part of this. They're helping boost this 1/3 that is underperforming to the best of its capacity. So in a nutshell, I would like to tell you about each one of these systems. Literally 1 or 2 slides for each of them, for you to be more clearly aware as to the functions and the benefits that these systems provide. So, this is the system for patient logistics management, Insight system. As you can see, it allows for full-fledged patient flow control in the inpatient department. All the stakeholders of this process are receiving the information online in real time. We enable the reduction of patients in inpatient hospital stay. So that means the patients are traveling along the treatment pathway faster. It's also about better efficiency of OR diagnostics department and other departments' use. Better efficiency. This sort of transparency comes with a big extent of control, not just intradepartmentally, but interdepartmentally as well. This sort of control and transparency might not be liked by everybody. Well, the head doctor will like it, because ultimately, in this situation, he can play God, because he basically have a bird's-eye view of the entire clinic. However, trust me when I say it, there are also benefits for the staff. Certain benefits for the medical staff out there. It improves communication within the department, interdepartmentally. It also contributes, this is also the data generated at the places of deployment, at the sites of deployment. The number of calls go down by 39%. The number of conflict situations between the department goes down. This interdepartmental passing the blame is no longer there. So you can just pull it up easily in the software. Any conflicts can be resolved like that. That also means a 10% reduction of the patient stay in an inpatient department. More discharges, or more prescriptions by 23% when Insight was put into operation. Moreover, I would like to emphasize the benefit of this system in ICU and ER departments. This is always a chaos. Everybody thinks that it will be a right mess. Essentially, this is not the case. A Danish IT guy with his daughter, he brought her to an ER department, and he, well, having waited for a long time, he came up with this interesting software solution. Insight is Danish-made, and the figures that you see are the outcomes of its system implementation in Denmark and Nordic countries at large. 4% boost of OR performance. It was already high, a very high base to start with. 4% plus 4% is a very good performance boost. Another system of integrated OR Tegris is another product I wanted to talk about. It's merging the equipment and digital data flow in the OR into something combined, into something whole. These are the capability of this integrated OR. The system can collect and distribute high-quality video signal, collect and manage high-quality video signals. It can help put information on the monitors for video conferencing purposes, VC purposes, online DDX sessions, concilium sessions, educational purposes, and so on. What might be interesting to healthcare management bodies is archiving and documenting the data. So let me tell you why. It should also be clear, but I'll elaborate. Over 1,000 systems are installed globally. Integrated ORs called Tegris. I'm also citing published data. This data go to show that more information about the patient significantly speed up the decision making. It reduces the time frame of decision making. It means faster diagnosis and faster rehabilitation. Now, as far as data archiving goes, documenting this data, should there be any legal disputes, this information can be traced back easily to defend the position and the right doings of the clinics. Another system from the product portfolio of GETINGE is the TDOC system designed to centralize instrument and materials in central sterilization departments. This system contributes to the reduction of human factor impact due to high automation of all sterilization processes. TDOC enables use barcoding to backtrack the fate, the destiny of any tool in the inpatient department. It's dual control for counting, for making sure that the instruments were used to purpose. It also optimizes stock keeping, knowing how many sterilized kits are available at the warehouse, and to reduce the number of emergency sterilization, the sessions of emergency sterilizations. Now, this tool can be linked to a specific patient. It's also beneficial in some cases. We can backtrack, we can track a lot of complications, a lot of undesired consequences, a lot of factors. TDOC system operates for quite a long time now. Since 1996, this was the time of first installation. GETINGE is the global leader in this segment, and currently our clients include over 1,200 sites of sterilization departments, including super sterilizing departments. As a result, 45 countries of the world have implemented the system, and we have around 19,000 clients. This system is of modular nature. It's a modular system, which is a big upside. For this reason, depending on the budget, depending on the objectives at hand before the clinic, this system can be built up of these multiple modules to fit the needs. The benefits and gains that come with this system can be categorized into three separate groups. I won't enumerate all 9 here. The clinics that implement the TDOC system see a significant cost reduction for tools, because the tools are no longer lost, are no longer damaged, because the system can, among other things, can automate the selection of the sterilization program for a specific device or for a specific piece of equipment. It means no longer avoidance of damage. Automation rules out the human factor, as I mentioned in the beginning. It's better safety for the patient. Besides, last but not the least, it's also reducing the workload on the staff due to this high level of automation. Now, I believe, having heard all that, you will definitely agree with me that healthcare requires digital solutions, all kinds of digital solutions. Many of them have been voiced today and described today. The investment into software, they are justified, even though the systems come at a price. The global practice shows the reduction of mortality and the reduction of costs in inpatient departments. This global statistics is a very good rationale for these use cases. The quality selection of partners must be also implemented. We need to prefer more experienced partners. Quality in partner selection. It's not about sales, not about deploying these projects. It's also about follow-up, post-sale, post-marketing support, because they are quite sophisticated. Thank you very much for the understanding. If there are any questions, please feel free to ask. I realize that this sort of a concise presentation is not exactly the right format to talk about some challenging software bits. So make.ru, gettingi.ru, gettingi.com, these websites, well, we'll be pleased to have you there. Any questions, please? No questions. Thank you very much, Tatiana. Indeed, this has been very clear. Those of us who have stayed this long and listened to your presentation, we all agree that healthcare is about going digital. It's about investments. So yes, we fully support the points in your final slide. Thank you very much. Esteemed colleagues, this exhausts our agenda for today. I would like to thank all the speakers again with all the interesting presentations they've delivered. I would like to thank all the people present, because we have heard your questions, and we see that as a feedback. As feedback, there is information that people care about in this process of digitization. I hope and I believe that everybody has borrowed some valuable insights from this conference. We're looking forward to seeing you tomorrow at day 2 of our conference. Thank you very much. Commencer out.